So good afternoon, good morning, good evening, everybody. Welcome to this webinar on advances in oncology nursing practices. This has been brought to you by the Mahatma Gandhi Medical College Hospital, the Shri Ram Cancer Center, the Journal of Carcinogenesis, and the Carcinogenesis Foundation. And we'd like to welcome all of you and join in celebrating the Oncology Nursing Month. You know, when you look at patient care and you look at a chariot in which we are carrying the patient to good health, the two main wheels, one is the medical professionals, the doctors, and the other is the nurses and the nursing. And if I may be permitted to say so, I think the nursing wheel is as important, if not more important, than the other wheel. And for every single patient and the patient's family, the experience when they are in the hospital or when they are discharged from the hospital is directly proportionate to the quality of nursing they get. You may have a good doctor, but if you have a not so good nurse, then the aggregate experience of the patient or the patient's family is negative. And conversely, if you have a not so good doctor, but if you have a good nurse, then the impression and the experience of the patient on discharge is by and large positive. So all of you, all of our nursing colleagues are incarnates of Sarojini Naidu and Florence Nightingale. And in this Oncology Nursing Month, all of us medical professionals salute all of you and the fantastic work which you are doing. And to just commemorate that, we have this Advances in Oncology Nurses Practice webinar today. This will cover several aspects of oncology nursing, and which I hope will be of benefit to nurses in India and abroad. Quite a large part of our faculty is from the United States, and it is 3 o'clock or 4 o'clock in the morning for them. So you will please permit us, we have taken the liberty of recording some presentations, but I assure you that everybody who is presenting will join as soon as they wake up this webinar, and they'll be available and ready to answer your questions. So if you have any questions, please post them on the chat box, and in our panel discussion at the end of all the talks, our moderator will make sure that all those questions are answered. And I will also request our nursing faculty to answer as many questions as possible on the chat box as they can. So I'd like to acknowledge the help of Professor Gopala in organizing this program and my very dear friend Dr. Lalit Mohan Sharma, who is instrumental in these nursing activities which we do. This is really a passion with him. And once I finish my introductory talk, I will request him to take over. So we have several topics to be covered today. Can I have the next slide, please? Slide change, please. And you can see some of the topics over here. The nurse's role in surgical oncology, the nurse's role when the patient is receiving radiation treatment, how to prevent and treat extravasation, fluids and electrolytes and diet counseling during chemotherapy and radiotherapy, care of the central venous access devices, management of the pediatric cancer patients, prevention and treatment of the patient with neutropenia. If the patient is receiving immunotherapy, the new form of treatment, what should be the nurse's role and responsibility, the very important role of palliative and end-of-life care nurses. And then we'll have a comprehensive panel discussion of a good half hour, 40 minutes, which will cover all the practical aspects and also discuss your questions. So with this brief introduction and with this brief platform, I'd like to hand over proceedings of the webinar to my very dear friend and colleague, Dr. Lalit Mohan Sharma, who is also the co-director of this program. He will invite the chairpersons for the first session, and they will then invite the first speaker. So I hand over proceedings to you, Dr. Lalit, and thank you once again, everybody, for joining us.
Sir, thank you so much. And before we move to the academic session, may I request you to say a few things about dedication of this webinar in the memory of Dr. GS. So may I request you to say a few words about Dr. Gaurishankar Bhattacharya before we start the proceedings.
Thank you very much. We lost Dr. Gaurishankar Bhattacharya to COVID on the 1st of May. And Dr. Bhattacharya was my best friend, my soulmate, my sounding board, brilliant medical oncologist of this country, an out-of-box thinker. And I think he was one of the single most important persons to take oncology awareness, Indian oncology, to Europe and the USA. And we'd like to dedicate this nursing webinar to the memory of Dr. Gaurishankar Bhattacharya, the role of nurses, the importance of nurses, and the importance of nurses teaching and training was very, very close to his heart. And we are very happy to dedicate this webinar to the memory of Dr. Gaurishankar Bhattacharya. Thank you, Lalit, for reminding me.
Thank you so much, sir. Thank you. So with these sweet words and in the fond memory of Dr. Gaurishankar Bhattacharya, we start the first session. And to chair the first session, may I request Dr. Ajay Bapna. Dr. Ajay Bapna is one of the senior most medical oncologists in Rajasthan and in country. He is currently director and head of the Department of Medical Oncology at prestigious Bhagwan Mahavir Cancer Hospital in Jaipur. Along with him, Dr. Nitin Khuteta. Dr. Nitin Khuteta is senior consultant in the Department of Surgical Oncology at Shri Ram Cancer and Super Specialty Center in Mahatma Gandhi Medical College, Jaipur. And Dr. Manoj Mahajan, he is director in the Department of Medical Oncology at Pacific Medical College in the Udaipur city of Rajasthan. Many of us are involved in the nursing education at different platforms. And with this short introduction, may I request the chairpersons to start the academic session, please.
Thank you, Lalit. At the outset, I would like to really congratulate Dr. Hemant Malhotra and Dr. Lalit Mohan Sharma for organizing, webinar on a very important and a very different topic. So nobody had thought of doing a webinar on this topic. So I really congratulate both of you for organizing this webinar, and especially when this is an oncology nursing month. So without wasting any time, our first topic is the role of nurses in the surgical oncology. And to speak on this topic, we have Miss Hilary Becker from United Kingdom. She is the lead clinical nurse specialist for urologic cancer and University College London Hospital, NHS Foundation Trust, London, United Kingdom. It's really our pleasure to have Miss Hilary Baker with us, and I invite her to deliver her talk on the nurse's role in caring for surgical oncology patient. And I would also like to mention that the subsequent speakers will be introduced by Dr. Nitin and Dr. Manoj Mahajan. I think they must have joined the webinar by now. So I invite Mrs. Hilary Becker to please deliver her talk.
Hello everyone, my name is Hilary Baker. I'm the lead nurse specialist for uro-oncology at University College Hospital. Thank you very much for inviting me today to do this presentation on the nurse's role in caring for surgical oncology patients. I'm going to take you through a presentation and then there'll be an opportunity to ask any questions. So we're going to use a model of care, which is called the enhanced recovery after surgery. So I'm going to talk you through that today. So you may have heard it as being called ERAS, and there's lots of different models available. So the evidence shows is that patients who engage in prehabilitation before surgery, and that involves some form of exercise, looking at diet, looking at optimizing them as much as possible before surgery, they'll do much, much better than those patients who don't engage in prehabilitation. They are much more likely to have morbidity and mortality issues following surgery. So the best possible condition for surgery is patient education. We want the patient to be feeling empowered and educated and informed and feel supported for going through this surgery. We advise them on stopping smoking and also on alcohol intake. As I say, we optimize them, whether it be their diabetes or their anemia or heart or lung conditions. So we optimize them as much as possible. We decrease the amount of time that we fast patients. So for instance, if they're on a morning list, they will be able to eat and drink up until 12 midnight the night beforehand. And then during the night, they can have clear fluids up until 6 o'clock in the morning. We then give them a carbohydrate loading drink, which is just water and glucose, which then carries them through the operation. We always say to patients, this is a bit like running the marathon. So you need to be carbohydrate loaded beforehand. Obviously, if they're diabetic, we wouldn't be giving them this drink. And then during the surgery, we want the best possible management during the surgery. So minimal use of drips and drains and catheters. If we do, for instance, put in a nasogastric tube, we'll probably take it out immediately following the operation, either in recovery or high dependency. We use careful use of opiates, pain medication. So we tend to use spinal anesthetics and spinal analgesia. We don't use patient-controlled analgesia really much at all, because we know that decreases mobility, causes problems with bowel function, and also takes some time to be able to wean them off the PCA onto oral medication, which is what we want to do. And then minimal invasive surgery. We do a lot of that here at University College Hospital. Where I work, we've got 2 robots, which are used all the time during the working week. And the benefits of robotic surgery is there's not a great big wound to heal. There's minimal loss of blood. There's pain is minimal, and the recovery of the patient is much faster. Ultimately, you want the best possible outcomes for the patient. So you want them to get up and out of bed as quickly as possible. Sometimes following surgery, we get patients out of bed as soon as they've had their surgery, almost sitting out in a chair, as long as they're awake and with it, and can walk. We'll get patients out of bed as quickly as possible. And if they don't get out on the day of their operation, they certainly will do the morning after their operation. We give patients a diary which sets goals for each day that they're in hospital, and each day as they progress through the diary, the goals will get bigger and bigger and greater for them to achieve. We remove tubes as quickly as possible and drain so that they don't stay in situ for long periods of time. We make sure that patients move from IV fluids and IV medication onto oral medication. And we introduce food and drink very early into their post-op phase. Start with fluids and then gradually progress onto diet. And that may be a soft diet, to be soups and ice creams and jellies, things that are palatable and easy to digest, and then onto other food as the patient feels that they can tolerate it. And then we're again talking about onward discharge planning and how they will be getting home, who will be looking after them at home, and what support that they will need. So this model improves patient outcomes and satisfaction. It decreases complications, it decreases length of hospital stay, and improves use of hospital resources. So the benefits of enhanced recovery or rapid surgery or fast-track surgery, depends on what you want to call it, is it improves the patient experience and satisfaction. You can treat more patients because patients aren't in hospital for so long. You can empower patients to improve their quality of life. You reduce the length of stay and speed up the pathway. You reduce the post-operative complications, reduce the readmissions to critical care, reduce the readmissions after discharge, so we make sure that they are as fit as possible before they can go home. So things like eating and drinking, their wounds are manageable, their pain's manageable, they're able to walk a short distance, they're able to do a flight of stairs, they're able to manage whatever it is that they have, if it's a device or something like that, before they actually can go home. And we educate the patient any behavioural changes for long-term health benefits. So for instance, they stop smoking, we want them to continue to stop smoking. We don't want them to go back to smoking. Or if they do want to go back to smoking, we can look at something different, whether it be patches or vaping. And the same with alcohol. You know, try and reduce the amount of alcohol they had pre-op and continue that in the post-op period. So we can only really do this, this management of the patients, if we've got a multidisciplinary approach to it all. So that includes physios, nurse specialists, ward nurses, doctors, consultants, anaesthetists, everybody involved all together using this pathway of care. So this is the elements of enhanced recovery. As you can see, I won't go through each one of them, but I'll talk to you about, for instance, no bowel prep. So we don't give any purgatives anymore. The evidence shows that this really harms the gut flora. And we don't even give enemas anymore either. So what we do is we ask the patient 2 days before their big abdominal surgery to go on a low residue diet. So that means no fibre at all. No fruit, no vegetables, no nuts, no lentils, nothing like that. Does slightly constipate the patient before they come to have their operation, but afterwards the gut flora is intact and you can manage constipation much better than having a gut that's completely deprived of its flora. And also we introduced diet early on in the post-op period to actually get the gut going again. So at UCLH, we use the integrated lifestyle exercise. This is a model of enhanced recovery that we're bringing in. So we're trying to get patients as fit as possible before their operation, about 2 to 5 weeks beforehand. Depends on what time frame we have and how aggressive the cancer is and whether they've had neoadjuvant chemotherapy or not beforehand. So if the patient's not terribly fit, we want them to have some sort of physio online exercise sessions that they attend. And this is then supported by telephone follow-up to encourage the patient to engage in their physical activities and to do regular exercise. We optimize the patient for the diabetic pathway if they're diabetic. We also make sure that their psychological and well-being is being addressed if they have any issues, and that they're optimized anemia-wise as well. And that may mean an iron infusion before they actually have their operation. This is another model that's used at St Mary's Hospital in London, and this is used for the colorectal patients. It's called the PREPARE model, and it's used very, very effectively. And as you can see, there's common elements in it, like eating well, psychological well-being, physical activity. So it's a three-step approach: before the operation, inpatient stay, and after surgery. So I always say to patients, I want you to eat a diet that looks like a rainbow. It's got to have lots of colors on your plate. So we also say to patients, if you think about the Mediterranean diet, that's a very nice, very healthy diet. So lots of fruit and vegetables, some protein, sweets, which mainly are fruit. You can have the odd treat and the odd bit of chocolate or donut or whatever it is you want to have. Healthy carbohydrates, and also some fats as well. So olive oil or avocado. And get the patient used to drinking at least 1.5 to 2 liters of fluid before their operation. We want the patients to walk at least 30 minutes every day. Now, some patients may not be able to do that, so that you break it down for them. You say, well, you do 15 minutes in the morning or 15 minutes in the afternoon, or 10 minutes in the morning, 10 minutes in the afternoon, and 10 minutes later on in the day. And also would like them to engage in some sort of resistance training as per this picture. So not everybody can go to the gym, not everybody wants to go to the gym, not everybody wants to do lift weights. So there's other things like doing yoga or Pilates or engaging in something like that, in some sort of resistance training exercises. The problem is, as we get older, we do lose muscle bulk. And so it's really important to keep that muscle bulk intact. If you don't, we end up with frailty, and that's where patients become less mobile, they lose weight, they become cognitively impaired, they're much more likely to have falls, they'll have poor balance and gait, and they'll be very, very tired as well. So the frailty score we do for patients, particularly if they're elderly and are not very mobile. And then here's a slide about walking. I mean, walking is hopefully people can do this, as it does really, it boosts mood, it boosts your heart, it fights weight gain, it cuts the risk of diabetes, it lowers the odds of some cancers, and it strengthens muscles and bones. Sleep is really important. We want patients to get about 7 to 8 hours sleep a night. Some of them may not be able to sleep very well because they've got symptoms or they're anxious, but it's about getting patients to really realize that sleep is important. And maybe if they engage in what I call the 3-2-1 approach, so 3 hours before they go to sleep, they have something to eat, nothing more after that. 2 hours before they go to bed, they do some sort of relaxation, whether it be watching television or watching a video or something like that. And then 1 hour before they go to bed, they stop all blue light activity. So nothing on their phone, nothing on the television, nothing on their iPad. And they indulge in something like reading a book or doing some meditation or deep breathing exercises, and that will help them to sleep. If they need to have a sleep in the afternoon, we also encourage that. So try and get as much quality sleep as possible. Mental health. So we do try and address this. As nurse specialists, we're trained to do this. We're trained at level 2, psychological support. And we do this through using an assessment tool to see how the patient is and how distressed they are. Hopefully we can address most of the issues with the patient by just lifestyle and education advice. But if they have a serious psychological issue like depression or severe anxiety, then we'll refer them for psychological support. And these are just some things that we say to patients, try and relax, try and take it easy, remember to breathe, perhaps engage in some sort of meditation, go outside if you can do. I know it's been difficult in the last year with the pandemic, but it is really important to try and get some fresh air and try and be in the best positive frame of mind going into the surgery. So we know common physical problems following surgery are pain, nausea, mobility, eating, altered bowel habit, and anxiety. And once these all have been managed as an inpatient, she can then get the patient home. But these are quite often the issues that hold a patient up, including if they get a clot in their lungs or their legs, they get a chest infection, they get a wound infection, or they get a paralytic illness. This can increase morbidity, mortality, length of stay, and quality of life of the patient. So when we review the patients on the ward, we use this an acronym, DREAMS. So we're talking to the patient every day about when they're going home. We're going to set a date sometimes when we know that they're ready for it to go home, so that their family and their relatives and their friends and their home is all prepared for them to go home. We will review what drips and drains they've got and try and get rid of them as quickly as possible. We want them to be eating and drinking. So as I said, we start with some sort of drinking first of all, and then going on to a soft diet and then on to a main diet. Sometimes we have to put the patients on some sort of diet sheet in order to monitor actually how much they're eating. They need to go back to that rainbow plate of eating. Analgesia, so want them to get them off IV pain relief or subcutaneous pain relief onto oral medication and take that on a regular basis. We want them to be as mobile as possible, so we get them out of bed and moving. You know, if they're not sleeping, they should be really sitting in the chair, or if they're sitting in bed, they need to be sitting upright. And then sleeping, trying to get them to have good quality sleep whilst they're in hospital. That's very difficult to do because at night times there can be a lot of activity going on. But it's just about having the ward, having a regime of when they put the lights out, when it's quiet, and even having a rest in the afternoon where the blinds are all pulled down and no visits are allowed, and minimal activity goes on the ward for an hour, gives the patients a chance to have a proper rest. So we know the patients that don't have good post-op pain relief are much more likely to be anxious, they're not sleep very well, they're more likely to get pulmonary compromise, so like hypoxia or infection. They're more likely to get tachycardia and increased oxygen consumption. So pain relief is very, very, very important. As with surgery, it can be very deconditioning for a patient. So you can get a patient really fit and well for surgery, and then they come in and have their operation. It's a big operation. And if they have prolonged bed rest for one reason or another, then that causes an acute decline in their performance status, which then leads to muscle weakness, low physical activity, and more at risk of having falls and fractures and increasing their lengths of stay. So we just need to be mindful of this, that big surgery, cancer surgery can be very debilitating for patients. So you're going to be tired of hearing me saying this, but we do want the patients to be mobilizing as much as possible. So we want them to have good pain relief, and we want them to walk. We want them to get up, get dressed, and get moving. And we tell the patients that this is very much what we want to do. And I will go up on the ward and I will nag patients to get up. I will go and walk patients myself up and down the ward to get them to mobilize, because we know the benefits. We know that it's going to reduce all these complications that they can have, including, the bowel not working, where they get constipated, they don't pass any wind, they become very bloated, and become very uncomfortable. They'll also need to wear their support stockings for, if it's big abdominal surgery, for at least 28 days, and they need to have 2 pairs, one to wear and one to wash. We want patients to make sure that they do brush their teeth twice a day. We all do our teeth twice a day, so the patients should continue to do that whilst in hospital. We don't want them to get any dental decay or to get any gum disease whilst in hospital, because this can put them at risk of other problems. Get them back to drinking lots and lots of fluids again, to 1.5 litres to 2 litres. Get them doing nice lot of deep breathing exercises. This helps with anxiety, as well as getting rid of any stale air that they may have in their lungs as a result of the surgery. And as you can see here, the man's holding a cushion over his tummy after having abdominal surgery to support his wounds. And then, as I said earlier, we need to get them back to this rainbow diet, this lovely plate of food of asparagus and tomatoes and nice piece of fish. Get them eating. They may not have much of an appetite, but they do need to get back to eating. We have an exercise alley on one of the wards where patients can learn how to do simple, non-straining, very simple exercises to help them get their fitness back on top of their walking and doing the stairs on a regular basis. So the National Cancer Survivorship Initiative is all about personalised care, and this is about patients taking responsibility for their own care, feeling empowered, feeling educated, feeling well supported, both in the community by primary and secondary care. They need to know what are the red flags, what they need to identify, what they need to be worried about, and who to contact if they get any problems post-operatively. So this can be shared care between primary care and secondary care. And if necessary, they can come back into secondary care, although we try to avoid this by saying to the patient, as early as possible, address the problems that you may have. So enhanced recovery programs aim to deliver high quality 21st century care, which as healthcare professionals, we know from clinical evidence will ensure that all our patients with shared decision making will benefit from this multidisciplinary approach to patient care. So thank you very much for listening to me. I hope you have some questions. My email address is here. If you'd like to send me any questions by email, I'm very happy to address those. I have put on some resources, so there's Top Med Talks that you can log on to, and enhanced recovery videos on YouTube. And I've also put some references here to support my talk. So thank you very much for listening to me, and I look forward to any questions you may have.
Thank you, Hilary Baker, for the nice, exhaustive presentation about nursing care in cancer surgery patients.
Thank you.
You have completed it in a very good manner. So I think Dr. Lalit Mohan Sharma wants to ask some question. Yes, Lalit.
Yeah, thank you so much, Baker, for your excellent presentation. It's a true learning, in fact, and we got a lot of insights from your lecture. Again, my common question, like about the antibiotic uses. So how commonly you use it, for how long you use antibiotics in a clean surgical case?
So we try to use the minimal amount of antibiotics at all. We might use them in induction when they're being anesthetized, but post-operatively we don't tend to use them as routine. And if we do need to, we seek microbiology advice. We're trying to minimize the amount of antibiotics used in surgery.
Great.
Because it develops resistance and all sorts of other problems as well.
Yeah, thank you so much. And you said something about the diet one night before the surgery. So can you explain to us again that what dietary precautions you keep before surgery?
So before big abdominal surgery, we put the patient on a low residue diet for 2 days, because we know that the evidence shows us that by using any sort of purgative of any sort, it upsets the gut flora. So we put them on a low residue diet, which is basically like it's basically protein and carbohydrates. And then the night of their operation, before they have the operation, they can eat and drink up until 12 midnight, and then they can have clear fluids during the night. So that's black tea, black coffee, and water if they're on a morning list. And then at 6 o'clock, we give them a carbohydrate loading drink, as long as they're not diabetic. And that then sort of carries them through the operation with some calories. As we always say to patients, this is a bit like running the marathon. So we need to carbohydrate load you first, and then once you've got through the operation and you're swallowing okay and you're not feeling nauseated, we'll start you on fluids and then start you on a soft diet as tolerated.
Thank you so much. Thank you. Over to Dr. Kuteta, please.
Thank you, Dr. Lalit. So, Dr. Lalit, I would like to ask you a question. You have completed it in a very good manner. So I think Dr. Lalit Mohan Sharma wants to ask some question. Yes, Lalit.
Yeah,
Yeah. So our next session, next 20 minutes will be spoken by Mrs. Emily Engstrom from USA. She is a senior.
Sir, you are muted.
Am I audible?
Yes, yes, you are audible now.
She is a senior manager in clinical services and operations, Emory University Hospital, Winship Cancer Institute, Georgia, USA. She's going to speak about, as we know, the radiation therapy is one of the main modalities of treatment in cancer patients. So she's going to speak about the basic principles of radiation therapy, radiation safety, and nursing interventions for skin care and mucositis associated with radiation therapy. Mrs. Emily Engstrom, please.
Hi, good morning or
Good morning.
afternoon for you. It's bright and early here. So thank you for having me, and I'll go ahead and share my screen for you. Does that look okay for you?
Yes, ma'am.
Good, thank you. So again, thank you for having me. I have been a radiation nurse for about 22 years now. Absolutely love the field. I love the technical aspect of it, and I hope that I can share a little bit of my knowledge from my years of experience with you. So first of all, quite a lot of nurses are not familiar with radiation. They've worked in oncology for years, and they may work in the medical oncology area or the surgical oncology area, but they don't get a chance to see radiation. So they don't really have a good understanding about what happens here. It's all kind of a mystery. So just a basic radiation are high energy particles that are used to damage or destroy cancer cells or the abnormal cells. So, you know, we do treat benign diseases as well with radiation. And so those are just abnormally dividing and growing cells, just as the cancer does. The radiation directly damages the DNA of those cells and creates free radicals that in turn damage further DNA. And when this damage occurs, those abnormal cells will then die. They're not able to repair and rebuild. Our normal healthy cells have normal DNA, and it's able to repair and rebuild. So there's a lot that we do, and we'll talk a little bit about that to help that process take place. So there are a few types of radiation that are commonly used. External beam is the most common. Here in the US, we have a couple of different types of external beam treatment. Typically, photon and electron beam therapy are the most common. Photon beam treats deeper tissues, and electrons treat superficial tissues when we're only trying to get within a couple of centimeters below the surface, either the skin surface or just below the skin surface. We use electrons. Otherwise, we typically are using photons. We are very fortunate here at Emory to also have proton beam therapy, and protons treat in a whole different way in that we have less of an exit dose of that radiation. The dose of radiation is delivered directly to the tumor, and then the dose rapidly falls off so it doesn't then exit the body and create side effects from that. We also use radioactive seeds. These are when we want to get the radiation as close to the tumor as possible, again, without causing damage to surrounding tissues, typically because there are highly sensitive areas, such as in the prostate. We would like to spare the bladder and the rectum when we're treating the prostate, so we're able to place those radioactive seeds either directly within the prostate or within an applicator that allows us to offer the radiation to the prostate without leaving it behind. And we'll talk a little bit about that in a minute. There's also systemic radiation, which is an injectable form of a radioactive substance, such as something like iodine that's used to treat thyroid cancer. There are other types of systemic radiation, such as strontium. Strontium is used to treat patients who have myelomas. It can be used. There are other treatments that are used to also treat patients who have widespread metastatic bony disease. So a couple of different things and different precautions that come up with those patients. So why do we use radiation therapy? We have a couple of reasons. We have a curative intent. So we may be using the radiation with or without chemotherapy, and we're intending to actually cure the cancer and prevent it from ever coming back, or prevent it from coming back as long as we possibly can. We have local control, which is when the radiation is intended to just stop the cancer from growing, and this would be such as in a late stage breast tumor that can't safely be removed by surgery, in a bladder tumor that's not able to be removed by surgery. Also in sometimes we have head and neck cancers, such as those that are near the larynx, when we don't want to do a laryngectomy, and we may just treat that with radiation to provide local control depending on the patient's status and situation. We can use prophylaxis. That's when we treat an area with radiation, and we want to prevent any microscopic cells that may be in that area from then developing and creating tumors. We see this commonly in small cell lung cancer. Small cell lung cancer loves to metastasize to the brain. And so frequently we will treat the whole brain with radiation therapy to prevent those cells from turning into tumors. We also have palliative intent radiation. When we treat palliatively, our patients receive radiation to help with side effects of their cancer. We're not intending to cure them. We're not intending to provide really any control of the disease. We know that the disease is going to progress, but we want to give them the best quality of life that they can have. So they may have significant pain and not want to be on high doses of opiate narcotics. So we can treat those areas with radiation and provide some pain relief. Also, if they have a large tumor, such as compressing the superior vena cava and causing symptoms, we can treat that as well and provide some relief there. Benign diseases we commonly treat are things like keloid scars or heterotopic bone. These are just overgrowths of tissue, and the radiation will halt that overgrowth and prevent those from happening. So as far as radiation safety goes, this has really changed over the last 22 years that I've been in radiation. External beam has always been very similar to the X-ray radiology departments. When the LINAC accelerator is on, that's when the radiation is being delivered and emitted. We are not in the room with those patients so as to avoid any dose of radiation to the staff. But those patients are not radioactive. There are no precautions necessary once they walk out of that room each day. There's no issue with radioactivity. And this is a common question from patients. They don't understand how we can give them radiation and then they're not radioactive or they're not carrying around radioactivity. The radioactive beams actually do the damage, and then when the beams are turned off, the radiation's gone. And I usually use an example of a light bulb with our patients. When I turn on the light, it's there, and when I turn it off, it's gone. So that helps them understand that process. When I started in radiation, the brachytherapy that we did, that type of radiation where we want to place radioactive seeds in the tumor or as close to the tumor as possible, we mostly did what was called low-dose brachytherapy. This is where we actually did a couple of things. It's commonly known prostate seed implants, where we will place radioactive seeds actually within the prostate. When we do that, those seeds are left there for life. They never come out. They stay with the patient. They will decay over time, and so the patient does have some radioactivity, and we teach the patient and the family about that up front when they go home. They can go home, but there are some precautions they need to follow. And then we also used to use it very commonly for GYN cancers. We would admit our female patients to the hospital, and then place applicators where they needed to be, and then place those radioactive seeds in those applicators. Patient would stay in the hospital for a few days based on the dose. We would time it so that we would know when to go back and retrieve those radioactive seeds. We would retrieve them and then remove the applicator, and the patient could go home. Again, they're not radioactive because we're taking those seeds out. But it did cause some level of dose to the staff when we did that. Now we almost exclusively use high dose rate brachytherapy. This allows us to place applicators where we need those radioactive seeds to go, and then we're able to place the patient in a safe room, connect them through transfer tubes from those applicators to what's called an afterloader machine. Then we come out, close the door, and the system sends those radioactive seeds into the applicator as we prescribe for the different times of dwelling in the applicator to receive the proper dose of radiation. So again, no risk to the staff, and the patient gets the dose of radiation where it needs to be, and then that radiation goes right back into the unit. It never touches the patient. It's not contaminated in any way. And then they've received the dose and they can go home, and they're, again, not radioactive, so they don't have any precautions to follow. So it works very well. One of the very common side effects that we see with patients is mucositis. It's commonly caused by the radiation to the mouth and the throat areas, the nasopharynx, oropharynx, hypopharynx. Those are the most common areas. We can also see some changes when we're treating the rectum or the anus in those mucosal tissues as well. But for this purpose, we're talking mostly about oral mucositis. Patients will have a decreased taste, dry mouth, thick mucus, mouth sores, risk for bacterial and fungal infections. So we want to pay attention to that. We want to be aware of that very early on and be proactive so that we can help prevent any really significant effects from the mucositis. Some of the interventions that we actually recommend are dental care prior to the start of radiation. Even here, that can be a luxury. Many patients don't have dental insurance here in the US, and so it can be difficult for us to find a dentist who's willing to take them on. But we do like to try and get them looked at and make sure that they're not having any major issues before we embark on this radiation therapy with them. We also recommend that prior to starting their radiation, they begin rinsing their mouth at least 3 times a day with a baking soda and water mixture. This kind of helps create an alkaline environment within the mouth and helps prevent some of that mucositis, as well as improve, there's some anecdotal evidence that helps it improve cell death with the radiation in an alkaline environment. As far as the baking soda and water mixture goes, there are, I think about everyone has their own recipe for that. You know, I was always taught anywhere from 1/8 to 1/4 of a teaspoon in about 1/2 cup of warm water. What we typically recommend for our patients is that they use a refillable water bottle, and they make at least 24 to 32 ounces of this water mixture and keep it with them during the day, and just rinse their mouth as often as possible. Helps keep it clean, and it's just a great thing for them to do throughout the course of treatment. We also recommend that they use a soft or an extra soft toothbrush so as to decrease any abrasions to the gum and tissues, as those are going to become more sensitive, and a low fluoride toothpaste if possible. We do want the fluoride has a tendency to burn those tissues. So we want to be very careful about that. So if that becomes an issue and they notice they're having burning, we'll switch them to a non-fluoride type toothpaste. We also recommend avoiding alcohol. Any citrus, and alcohol includes anything that's in a mouthwash or fluids that they're going to drink, any type of alcohol. Citrus foods, tomato foods, spicy foods, and extreme temperatures on their foods can also be difficult for their tissues within their mouth and increase that mucositis. We have something here that we use called Magic Mouthwash. Again, this is another one of those little concoctions that just about every oncologist I've met over the years has a little bit different formulation that they like. So I'm happy to discuss that with anyone and give some recommendations if you need something different. But there are all sorts of things that can help. It helps take down the inflammation, kind of helps with pain directly at the site of pain, and then also helps provide a little bit of light numbing so that a patient can eat a little more comfortably while they're going through treatment. So that's where I have to end for this portion. I'm going to talk about skincare in another section here, but hoping to answer any questions that you may have about this kind of quick update about radiation and mucositis.
Thank you, Emily, for a very nice presentation about the principles of radiotherapy and the management of mucositis in detail. Do we have any questions here, or we continue with the next session?
So, Dr. Nathan, can you allow me for one question?
Sure, please.
Yes, Emily, it has been very nice presentation. I'm so thankful to you for joining us so early morning. And
Sure.
thank you. So my question remains, like in patients with severe mucositis, at my place in India, most people are fond of eating very spicy food. So that remains a big challenge that they are not able to eat that. And if we give them some local anesthetic agent, the taste remains a masking effect of the taste. So what is your recommendation? How should we counterbalance this part?
That is such a difficult issue. And we have many patients. We have a very diverse population here in the Atlanta area. And we actually run into this on a regular basis. Many patients, as part of their culture, they're used to having very spicy foods. And if it's not bothering them, it's okay. It's not going to cause harm. It's just that many times if they start getting to the point where they say, I just can't eat, it hurts, we try and help them understand if they can just reduce the spiciness even, then they can do that. One of the concerns we have with using too much of the local anesthetic is then an issue with choking, and we don't want that to happen. So we're very careful about that. These magic mouthwash concoctions that we use can be helpful. But yeah, we really do try and help them figure out a way to flavor their food in other ways with herbs, other seasonings that maybe don't provide as much of that hot spice that they're used to, knowing that that's going to get better and they're going to heal and they'll get to go back to that soon after. So we try and help them through that.
Thank you.
So we come to the next session, and as we know, in cancer, IV access is very important, and we have been using it regularly for IV and blood transfusions and sample collections and all, and chemotherapeutic agents that we push in the patient by IV access. And if there is an extravasation of these drugs, chemicals, or chemotherapeutic agents, there's a disaster that happens at the local tissue. The tissue damage is there, ulceration is there. For that, now we have a speaker, Mrs. Lori Bessel from USA. She is an executive director, Center for Global Cancer Medicine, Dana-Farber Cancer Institute, Boston, USA. And she's going to tell us and speak us about the extravasation, how to prevent, and what is the treatment if it has happened. So may I ask Mrs. Laurie Buswell to start the presentation, please?
Thank you very much, and good afternoon to everybody. I am going to just share my screen. Can everybody see my screen?
Yes, ma'am.
Okay. So thank you very much for this opportunity to talk to you about extravasation, which is clearly sits within the nursing domain of practice. And what I hope to cover today is really understanding the responsibilities of nurses in preparation and administration of vesicant chemotherapy drugs, and to provide the nurses here with information regarding prevention and management of vesicant extravasations. And I want to just say that prevention is the best thing that you can do, because if you do have an extravasation, they are very, very difficult to manage. So I wanted to just start with a definition of what a vesicant extravasation is. And so it is a leakage of certain drugs called vesicants out of the vein into the tissues around the vein. And vesicants can cause blistering and other tissue injury that may be severe and can lead to tissue necrosis or tissue death. The vesicant chemotherapy drugs that we typically use in oncology are either DNA binding drugs or non-DNA binding drugs. And I will only say that the DNA binding drugs produce a much more severe reaction in the skin than the non-DNA binding drugs, and management of them is a little bit different. And so these are things like nitrogen mustard, which we don't see used that much in the United States anymore. I don't know if you use it as part of a MOP chemotherapy for Hodgkin's disease. We tend not to use nitrogen mustard, but the anthracyclines like doxorubicin, daunorubicin, epirubicin, idarubicin, dactinomycin, mitomycin C are all very frequently used drugs, as are the taxanes and plant alkaloids like vincristine, vinblastine, vinrelabine. So these are the drugs that we're talking about when we talk about vesicants. And all nurses should be acutely aware of what are vesicants and what are irritants. And so I just want to say a couple words about irritants. So there are a lot of chemotherapy drugs that are classified as irritants, and they cause inflammation in the vein wall. They usually don't cause tissue damage unless there is a large amount of one of these drugs that has extravasated. But again, if a patient is getting carboplatinum or dacarbazine is particularly irritating, and they complain of pain or burning at the site, you want to pull that IV and start another IV in another arm, in the other arm, or higher up in the patient's arm. So one of the first things that nurses really need to do when they administer chemotherapy, particularly that include vesicants, is they need to be aware of the patient. So as part of their patient assessment, they need to understand whether or not the patient is at risk for developing an extravasation. And the patient risk factors are patients that have altered sensory perception. So, you know, they can't feel, pain the way that they normally would in one of their arms, or they have peripheral vascular disease, so they have compromised circulatory system. I don't know if you use implanted portacaths, but those are a disc in the chest usually with a tube attached. An implanted port is a central venous access device, which are great when they work well. And if they are deeply implanted and you have to go through a lot of subcutaneous tissue in order to access that portacath, that patient would be at risk for an extravasation. Exposure to non-chemotherapy irritating agents like potassium. So, a lot of patients that get cisplatin as part of their chemotherapy, they tend to get a lot of potassium replacement, and that's irritating to veins. Patients that have repeated peripheral chemotherapy administration or multiple venipunctures are particularly at high risk. If a patient has impaired communication skills or cognition and might not be able to understand the signs and symptoms that you want them to tell you about, or they can't communicate with you, those are patients that are at risk for extravasation. Highly mobile and active patients. So if you're treating somebody and they're, up and around and, doing exercises in their room, those patients are at risk. Patients with poor education or poor understanding of information are at risk. Patients with lymphedema, so anybody who has had an axillary node dissection, we tend to stay away from extremities with lymphedema. So you would want to avoid those extremities. Pediatric and geriatric patients are at higher risk. Poor or no blood return from an IV site or a venous access device. If you don't have a blood return, those devices should not be used unless in the case of a venous access device, a central venous access, you get a dye study to confirm patency and placement. Patients that have poor venous access, if a patient comes in, once every 2 or 3 weeks for chemotherapy and it takes 5 tries to get an IV in that patient, that's a patient that you as a nurse would want to highly advocate that they get a central venous catheter, central line access. It's not fair to the patient. It's not fair to put them at risk. Patients that are obese and you're using peripheral IVs to give your chemotherapy and they have deep veins, those patients are also at risk, as well as patients that have small or fragile veins, and we often see this in elderly patients. And then obviously treatment duration, the longer somebody is on chemotherapy treatment, the higher risk they are for extravasation. So really important as a nurse, when you meet a patient that is going to be getting a vesicant, say it's ABVD and the doxorubicin and the vinblastine are vesicants, and the dacarbazine is a highly irritant. And if they come in and on the first week you have trouble getting an IV in them, that's when you want to call the doctor and say, look, they need 11 more of these treatments and we're not going to be able to put their treatment. So central venous access devices are very good for patients who are going to get a lot of vesicant treatment. There are also some nurse-related risk factors, and those include somebody who has extensive experience with vesicants and begins to be overconfident in their ability to give it. Sometimes their overconfidence leads them to have extravasations. Failure to identify patients at risk. So all those factors that we just went over, if a nurse doesn't do a good assessment and, misses some of those risk factors, that's really a nursing responsibility. Improper venipuncture technique, improper vesicant administration technique, inexperience with giving vesicants. You know, not even knowing what the vesicants are is a risk factor, you know, so nurses need to be well educated, oriented. If a vesicant administration is interrupted because the nurse has, you know, 6 other patients and somebody's vomiting and she has to leave the bedside giving a vesicant to tend to somebody else. The IV site selection, so we never want to choose the dorsum of the hand or the wrist area or the antecubital area for our IV when we are giving a vesicant. Lack of time and lack of training have also been identified as risk factors related to the nurse. There are also device and drug-related risk factors. So device factors can be improper port needle placement. So again, when somebody has a portacath, that disc in their chest, and there's a special needle you use to put into the septum of the port. If that is not placed properly, if it is, you know, sitting in the skin but hasn't penetrated the septum, then you would be giving drug right into the subcutaneous space. Migration of the catheter tip of the venous access device, pinch-off syndrome of a venous access device. So that's when the catheter goes between the clavicle and the first rib and gets pinched off and can cause a tear in the catheter. And then using a venous access device without a blood return. And then the drug factors are concentration. So if something's highly concentrated and gets extravasated, then you are going to have a bad extravasation, as opposed to if something is more dilute. The duration of the infusion, so longer infusions, higher risk. The route, infusion versus push, and I'll talk about the different ways of giving vesicants. And then vesicant properties. So remember, I told you that the DNA binding vesicants are more severe than the non-DNA binding vesicants, and then the volume of the diluent. So the more diluent you have, the less chance of having a bad extravasation. So when nurses are giving vesicants and if they have an extravasation, usually the patient will have some pain, and they would describe it as a burning or a stinging or a sensation of coolness around the administration site. Some patients may not experience pain at all. And therefore, you know, pain can't be the only thing that you rely on. Sometimes there will also be some erythema in the area, but often there is swelling in the area. So if the IV catheter has come out of the vein and you're dripping or pushing a vesicant, you will see that infiltration rate at the site. And so you want to make sure that that you can see the IV site very, very well, so you can keep your eye on it as that either IV infusion or your push is going in. Sometimes swelling is a little hard to tell if you have an implanted port, because again, it's in the subcutaneous tissue of the chest wall. And then obviously one of the biggest signs and symptoms is loss of a blood return from an IV when you are giving a vesicant. And if you lose a blood return, if a patient complains of pain, if you see swelling, you know, then those are all signs of an extravasation, and you want to stop. And I'll talk about the procedure for that in a minute. And then the other sign is if you are giving it through an infusion, another sign of an extravasation is if the infusion begins to drip really slow, much slower than what it had been dripping, or if it stops completely, then that's an indication that it may have been an extravasation. What we tend to see later on is, you know, so these are delayed signs and symptoms. So in the area where the extravasation occurred, you will see ulcerations, and if they're not treated with an antidote. And I'm going to talk about the antidotes in a few minutes, but you'll see blistering of the skin, discoloration of the skin, induration, and that usually begins around 1 to 2 weeks after the suspected extravasation. So you need to instruct your patient about those things. Then the skin will start to peel and begin to slough off, and then you'll see tissue necrosis. And sometimes the tissue necrosis requires surgical debridement and skin grafting or a flap replacement. Pain usually increases in intensity over that time period. Sometimes there can be damage to underlying tendons and nerve, causing sensory impairment and permanent damage that can result in severe disability and discomfort. And sometimes that nerve damage, permanent nerve damage, or a limb might need to be amputated depending on the extent of the extravasation and damage. And so I want to just switch a minute to show you, I want to just switch. I want to show you some extravasation pictures, and I don't have permission to use these, therefore they're not in my talk, so you won't get these, but I want to show these to you. So this is a chest of a woman who had a portacath, and this was a week or so after she had an extravasation. So the date of this was February 14th, okay? And this is what it looked like. So you can see the redness of the area. And then you can see 14 days later, the area is much more red, beginning to blister and peel. And then what you see is on March 18th, so, you know, about 3 weeks later, that site had to have surgical debridement. And then you can see June 5th, so now several months later, granulation tissue forming around that and beginning to heal. And then you see in December, so remember the first, the extravasation happened in February, so 10 months after the extravasation, the area is healed, but you can see the damage that this has caused in her subcutaneous tissue and skin. And then this is just a picture of severe tissue necrosis after vesicant extravasation in a wrist. And, you know, this is what can happen in an extravasation. And, you know, if you've never seen one of these, and quite honestly, I've never seen one of these in my career, but these are pretty devastating. So you want to do everything that you can do to prevent an extravasation from occurring, and don't rely on, oh, we, you know, if it happens, we can manage it, you know, like nausea and vomiting. An extravasation is a pretty significant event. So in terms of preventing extravasation at the patient care level, you want to educate your patient about signs and symptoms of an extravasation so that they know to tell you if they feel pain or burning or even something funny about the site. You want to avoid extremities with impaired circulation and lymphedema. You don't want to use the hand, wrist, or the antecubital space. You want to advocate for venous access devices for patients that are going to get long-term administration, have poor venous access, or for pediatric patients and elderly patients. When you're giving the vesicant, you want to make sure that you can clearly visualize the IV site throughout the infusion. You want to inspect the IV site or the venous access device during the infusion for redness or swelling. You want to ask and instruct, you want to actively ask the patient, is it feeling okay? You know, do you have any pain or burning? And you also want to make sure that you've told them to report any pain or burning at the IV site. And you want to maintain a free-flowing IV to dilute an IV push or a piggyback vesicant. So if you give it through infusion, you want to have an IV going so that it dilutes the vesicant. You also want to make sure that you maintain a good blood return throughout the vesicant administration. If you do have a venous access device and it does not have a good blood return, you can push fluids through it, fluids drip well through it, but you can't get a blood return. You should not use that until you get a dye study that confirms that the line is patent and the tip of the catheter is in the correct place. If you are giving the vesicant through a peripheral IV, you want to make sure that you are using a good large vein, typically in the forearm are where you will find those veins. You always want to use a relatively new IV. So if a patient is in the hospital for a couple of days and they're due for a vesicant, if that IV is older than a day old, you want to start a new IV. You want to make sure that the IV site or your port needle going into a central venous access device, that they are well secured so that there is not a chance of patient getting up to go to the bathroom and all of a sudden they forget to push their IV pole and the needle or the catheter dislodges and now the vesicant is going into their subcutaneous space. The other thing that I didn't put on this talk, and I can add it and then send it to whoever can distribute it to you all, is if a patient comes in and they are going to get their vesicant through a peripheral IV and you and they have poor access, but it's a patient that has symptoms and they need to be treated right away, and there's going to be a central line put in at some point, but you have to use a peripheral IV. When you're looking for an IV site, you really should start low on the patient's forearm to put an IV in, because if you are unsuccessful, you want to move up more proximal, like higher up in the arm to try the next IV, so that when you are successful and you're putting the vesicant in and it goes into the veins and it's being returned into the core of the body, that vesicant isn't leaking out of other veins that you have attempted to put an IV in. And we see that. So if you start high up in the forearm and you get into the vein, but you've punctured the vein and that you've blown the vein and you move lower down, and if you are in that same vein, there is a chance that IV, that vesicant is going to travel up and then leak out at that prior site. And the same is true. You want to, at where I work, a lot of patients come in and have their blood counts checked through an antecubital stick, and then they go to the nurses for their to get their chemotherapy. And if they have had an antecubital venipuncture for blood, and we give a vesicant below that site, there is a chance that vesicant will leak out at that antecubital venipuncture site and cause an extravasation there. So you want to avoid that situation. At the institute level, in terms of, so for all of the administrators and leaders on this call, there are things at the institute level that you can do to help prevent extravasations from occurring. And those are things like making sure that when you hire new nurses to work in your oncology unit, that there is a training course for them if they have never worked in oncology before. And even if they have, you want to make sure that they know your policies and procedures and standard operating procedures for giving vesicants and everything else included in being an oncology nurse. So making sure that there is training and that it includes the proper vesicant administration technique. And that's not just telling them what it is and then expecting that they can do it, but it should include clinical competency observation so that somebody who is teaching them is sitting right beside them, giving vesicants and instructing them and telling them what to do as they're doing it. And it can even include practicing on companies make these fake arms where you can put an IV in and you can start the IV and you can get practice pushing drugs so that you know, it's a manual dexterity skill also, and handling the syringe and the IV and checking for a blood return. So you can even institute something like that in like a simulation lab to train new nurses. You should have an approved standard operating procedure for vesicant administration that outlines step by step what the proper technique is. And then even after you have trained nurses, you can institute an annual competency observation to validate that your nursing practice hasn't degraded in any way over time. And then the other thing that is really important is to monitor extravasation rates for potential spikes in your numbers. And the way that you would do this is you would ask help from pharmacy to let them know in a given month how many vesicants were dispensed from the pharmacy. And then you would want to have a system that all extravasations that occur are reported. And I'm going to talk about this in a minute when I talk about documentation, but you may want to consider having a special form that gets filled out if a suspected extravasation occurs. And you can use those forms, those reports, as a way to monitor what your extravasation rate is. And, you know, some extravasations, quite honestly, are very hard to prevent. You know, if there's a venous access device malfunction, like in the case of the picture that I showed you, that was a case where there was a leak in the catheter and nobody could have seen that. A nurse could not have prevented that. But you would want to monitor the rates and make sure that they stay at a very low level. And again, you know, these are institutional leadership administration level things that can be done to prevent extravasations. So if the nurse is going to give a vesicant by a peripheral IV, you would never want to use a pump because pumps put pressure on the vein. So you just want to use a free-flowing IV. You want to stay with the patient the entire time if you are giving it over a short infusion. And short infusions should not be any longer than 30 to 60 minutes. So the only way you want to give a vesicant is through either IV push or a short infusion through a peripheral IV. When you are giving the vesicant, either way, you want to verify a blood return every 2 to 5 milliliters for an IV push, and every 5 to 10 minutes if it's a short infusion. And again, you want to stay there and you want to monitor closely for any signs and symptoms of an extravasation. Vesicants through a central venous access device, you can either push those, you know, with a syringe. You can either give it as a short infusion over 30 to 60 minutes, or as a continuous infusion. And there are several protocols for diseases that we treat, like sarcoma, or multiple myeloma that require vesicants to be given over a continuous infusion. You want, again, to verify your blood return before, during, and after. You want to monitor the site throughout the infusion according to your institutional policy. You know, at my hospital, we check if somebody has a continuous infusion. We check the blood return 2 times a shift, and we have 3 shifts in a 24-hour period. So that gets checked 6 times in 24 hours. And then again, if there is any sign or symptom of an extravasation, you discontinue the vesicant administration. So if you're going to give the vesicant with an IV push method, there are 2 different ways of giving an IV push vesicant. There's a direct push method. And what this is you have an IV, you verify that you have a blood return, you have a syringe with saline flush, you flush it, you detach the syringe, and you attach the syringe with the drug in it. And then you would push the drug directly into the IV catheter. You would push it slowly. You would aspirate for a blood return every 2 to 5 mLs. Once you're done pushing the entire drug, you would discontinue the drug syringe. You would attach a flush syringe, you would flush it through, and then after you flush it, you would either cap the IV site or discontinue the drug. The disadvantage with this method is that you potentially, when you're done pushing the vesicant and you discontinue, you potentially could have a drop or 2 of blood under the IV site, which would contain chemotherapy, which, as you all know, is a hazardous drug. And so there would be some, chemotherapy exposure in this case. The other method, which is the method that we use at the hospital where I work and how I was taught, is IV push through a free flow method. And this also is called like a side arm technique. And so you would have a running IV into the patient, a normal saline or compatible solution, depending on what your drug is. And you would have that, dripping in at a slow rate. You would attach the syringe at a Y site closest to the patient. You would aspirate to verify that you have a blood return. And then you would allow the IV solution to flow freely, and then you slowly administer the chemotherapy agent as a push, allowing the IV solution to dilute the drug. You administer that at a rate of about 1 to 2 mLs per minute, unless there is another indication. If you are giving something like CHOP chemotherapy, where you have doxorubicin and vincristine, you want to make sure that you flush the line in between those 2 chemotherapy drugs, and that you flush the line, that you check for a blood return and you flush the line after you're done. As you might imagine, giving vesicants is a much more timely activity for nurses, a time-consuming activity for nurses, than it is to simply hang a bag of cyclophosphamide and let it drip in, and the nurse can go about other activities. So having enough nurses and them having the time to give vesicants is really important. I talked a little bit about continuous infusion vesicants, and I just want to say again that central venous access device administration is highly preferred. Much lower chance of an extravasation happening with a central venous access device than with a peripheral IV. And so when this happens, you want to check the blood return and IV patency according to the institutional policy. And this is where I said that at my institution that happens 6 times in a 24-hour period. You would connect the IV, the drug directly to the IV access device, or piggyback it into a main line. If you do a piggyback, you want to make sure that all of the lines are very secure with lure locks or a similar device.
Beg your
Yeah,
pardon,
you
Lori,
want it.
want to interrupt you because we are behind now. So
Okay, I'm
request
sorry.
you to conclude, please.
Yep. So let me just say that I will go really quickly. If an extravasation happens, you want to stop the infusion immediately. You do not want to flush the line. You want to disconnect the tubing, and you want to take a syringe and aspirate as much of the agent as possible from the existing access device, and then remove that catheter or port needle. You want to then notify the provider of the possible extravasation. With the provider, you can determine if an antidote can be administered. You want to measure and document the area, and if possible, take pictures of it with a date and time. You want to, depending on the agent, you want to apply warm or cold compresses for 15 minutes every 4 hours for the first couple of days. For the plant alkaloids, you want to use warm packs for alkylating agents, anthracyclines, and antibiotics. Want to use cold packs. Elevate the extremity. Document the event in detail: what size catheter, where it was, when it happened, how many cc's you think extravasated. Take pictures. And again, this is where I think a special form might be helpful. That patient should come back 24 hours later, 48 hours later, 1 week, and you should have follow-up at least through 3 weeks. Take pictures, and you may need to refer to a surgeon, physical therapy, pain management, rehab for evaluation. If you do have an extravasation, there are antidotes for alkylating agents, anthracyclines, and plant alkaloids. There is no antidote for anti-tumor antibiotics. And that's it.
Thank you very much for a very nice presentation. And I'll congratulate you for giving us the practical tips for evaluation and management of extravasation of chemotherapeutic drugs. Thank you very much, Dr.
Thank
So
you.
may I request now Mrs. Eddie Engstrom to come again and discuss about skin care during radiotherapy. Please.
Thank you. All right. So we'll get into the skincare. We talked about radiation therapy and what it does to damage the cells. The normal healthy cells get damaged as well. And so let's talk a little bit about what we see with that. The way we grade our radiation dermatitis, we use the CTEP, the Cancer Therapy Evaluation Program, version 2 toxicity grading criteria. Our nurses are all trained in this criteria. This is not just for dermatitis, but it's for all toxicities, both for radiation and for chemotherapy. There are toxicity gradings. So it's very helpful that we have something very specific that we can look at and know exactly what we're talking about, and we're not just making assumptions about what we're dealing with and treating. So this is very, very helpful. We go from grade 1, which is very faint erythema, dry desquamation, which is just some peeling of the skin, to more moderate brisk erythema, may have some small areas of moist peeling. Typically, we see those in creases or folds of the skin under the breast, under the abdomen, those sorts of areas. When we get into grade 3, we have larger areas of moist desquamation where the skin is peeling and it's moist, and we may have some pitting edema. And then we get into grade 4, this is where we start seeing really that skin necrosis, the ulceration, very deep ulceration, typically some bleeding, that sort of thing. I have to say, with the advances in radiation therapy that we've had over the last several years, it is very seldom that we actually see these grade 4 even the grade 3 toxicities for skin. So that's really been wonderful. It used to be a really big problem. Common reactions that we see to the breast can range anywhere from a grade 1 all the way up to a grade 3 or 4. And that goes with what I was saying. We really don't see those grade 3, 4s as much anymore with the improvements in the delivery of radiation therapy systems. Grade 1, 2 is the most common, and we can manage that very easily here in the clinic and teach patients how to manage that. Our lung patients will typically have a grade 1 or 2 erythema, mostly grade 1 erythemas, and that's typically seen on the back rather than on the chest, because that's where the exit dose happens, and that's where we see the majority of that reaction. Our head and neck cancer patients, their erythema can range from a grade 1 all the way up to a grade 3 or 4 if they're receiving concomitant chemotherapy as well. Again, that's also changed over the last many years. More of those patients are receiving immunotherapies as opposed to chemotherapies, and that has improved those toxicities from to the skin. So some of the things that we can do to prevent some of these skin toxicities have to do with teaching our patients to keep their skin clean and dry. We want to make sure that any areas where we have folds in the skin are free of moisture. We'll sometimes recommend that patients just dust plain cornstarch in those areas just to keep them dry. We don't want to use things like talcum powder, or some people have used in the past things like deodorants that they've put on the skin, and this can actually increase irritation. So something just like a plain cornstarch that can be dusted on the skin can be helpful in those areas where we have creases or folds in the skin. We do not want our patients to put any kind of product on their skin within 4 hours before their treatment. We don't want to have any type of product on the skin, moisturizing product on the skin at the time of treatment. Anecdotally, we know that this can potentially create a bolus effect, which could increase the dose of radiation at the surface of the skin and therefore increase toxicities. Again, this is an anecdotal. There's not been a lot of data to support that, but we do see it in the clinics on occasion when patients don't follow those directions and they put moisturizers on their skin before they come in. We also recommend that patients avoid any types of perfumes or alcohols in their skincare products. Those types of products can increase irritation. And we'd also rather that they not try something new to that area, as their skin may be more sensitive. And so we don't want that to cause other irritation and have difficulty deciding if the irritation is from the radiation or from another skincare product. As far as nursing interventions go, they're really very simple. We try and keep it easy. Patients can follow these. They work well. If you're going to have an irritation to the skin, you're going to have erythema, it's going to happen. And we just need to do our best to keep that skin intact and prevent any infection in that area. A gentle soap and tepid water is best. Rubbing or scrubbing in the area that we're treating, we really want to be very gentle to our skin as it's irritated. Gentle soaps, we just want something that doesn't have any kind of harsh chemicals like lye or antibacterial type soaps, anything with an abrasive in it, those sorts of things, any sort of exfoliant, whether it's chemical or physical exfoliants. We just want something very simple. And again, not using excessively hot or really cold water, just a very tepid water is most helpful. We typically recommend that patients avoid any type of shaving in the area that's being treated. The shaving, especially from Straight or safety razors can cause more irritation to the skin, as can the products that are typically used when patients are shaving. So we try and just avoid shaving during that time. Any hair that's in the area that's being treated is going to eventually come out anyway from the radiation. So if they can just get to that point, they usually do just fine. Some of the products that we typically recommend to our patients, plain aloe vera gel is one of the best things to use. It's moisturizing. It doesn't leave a residue or an oil on the skin surface. And it works very well in soothing the skin. Patients can actually put that in the refrigerator and use it cold. I've had patients try and put it in the freezer and that's too cold. So in the refrigerator is usually okay to keep it cold, and they can use that on the skin. It doesn't stay cold for very long, but it can be very soothing and it doesn't cause any problems. Coconut oil is a fabulous product. Most everybody in the world has access to coconut oil. It's very simple. Coconut oil is known to have antibacterial, antiviral, and antifungal properties. So that can be helpful to keep the skin moisturized and happy. Calendula is another product. It's a plant that creates a good moisture barrier and it absorbs well into the skin. And has been shown, we've had some studies that have shown some benefit to using calendula. Another product that I did not put on here is lanolin. Plain pure lanolin is another excellent product that absorbs well into the skin and does provide that deeper moisture. Really works well for these patients, especially for breast patients. We also recommend that patients wear loose fitting cotton clothing that allows air to circulate around the area that's being treated. This will also help with healing of the skin. We want to avoid the sun as much as possible, keep the area that's being treated covered from the sun, and use sunscreen in that area if you need to be outside, and if the area that's being treated is going to be exposed to the sun, definitely use sunscreen. And again, if you're using sunscreen, we want to make sure that sunscreen is off the skin within 4 hours prior to the radiation. As we know, sunscreens stay on the surface of the skin and we can create that bolus effect of the radiation. So we don't want to do that. And we also want to avoid extreme temperatures like hot or cold packs to the skin. We don't want to do that, as that can also damage. The nerves are not as sensitive and can't tell us that it's too cold or too hot sometimes, and we can end up creating a burn from the extreme heat or cold. So we want to avoid that. So those are quick tips. I know we're short on time, so I just wanted to answer those for you real quick. Do we have questions? Anything I can help answer that would be helpful to you? Questions about what we do here?
Thank you very much, Emily Armstrong, for the nice, excellent presentation on how to take care of the skin during radiotherapy.
Sure.
So the session is open for question and answer. If they are not there, then we can start the next session. Dr. Lalit?
I think coconut oil application she has suggested is universally available, and even in resource limited settings, this is very useful. And my radiation colleagues will agree to that helps in most of these patients. So she has covered, I think, the topic very well. And thank you, Emily. Thank you so much. And for Laurie, there are few questions in the chat box. So may I request you to please address these questions. We will try to take them in the panel discussion, but I'm requesting you to address them in the chat box as well. Thank you so much. And I think with this, we come to end of the first session. And thank you, Dr. Nitin Kuteta, Dr. Ajay Bapna, Dr. Manoj Mahajan for sparing time for this, chairing these prestigious sessions. Thank you so much, and I thank all the speakers, Hilary Baker, Emily, Laurie, for their excellent presentations. So thank you so much, Dr. Nitin Kuteta, and may I request now Dr. Rameshwaram Sharma to chair the next session. Dr. Rameshwaram Sharma is currently the Chief of Department of Radiation Oncology in SMS Medical College Hospital in Jaipur. SMS Medical College is one of the oldest and alma mater for most of people sitting here in the audience as doctors. Along with him, Dr. Surendra Beniwal. He is professor in the Department of Medical College. He is attached to Acharya Tulsi Cancer Center, which is a regional cancer center in Rajasthan, catering almost half of the population of cancer patients in Rajasthan. So with these kind words, may I request Dr. Rameshwaram to please start the next session, please.
Thanks, Dr. Lalit, for giving me opportunity to chair the session. The next topic is food and fluid during and after chemo and radiotherapy. And this will be discussed by Emily Armstrong from USA.
All right, so we'll get right into this, nutrition and hydration during and after chemo and radiation. So some of the common side effects from patients who are receiving chemo and radiation, specifically when they're receiving them together, is that can be an increase in side effects. We can see nausea, vomiting, diarrhea, fatigue, mucosal changes, and skin changes. And it all depends on the areas that are being treated, the type of radiation that's being used, the type of chemotherapies that are being used, and what the exact protocols are that are being given. So we have to take all of that into consideration and think about that when we're taking care of our patients. As far as hydration goes, the standards for hydration are about 10 8-ounce glasses of fluids per day. I know that most of us, especially those of us in the healthcare field, do not get 10 8-ounce glasses of fluids a day. But we do try and recommend that for our patients as much as possible. We want them to stay hydrated. If they can keep their cells well hydrated, this will help them through the course of their treatment. Their body will be able to heal and repair much more rapidly. We recommend that they avoid alcohol and caffeine as much as possible. We certainly do not tell our patients that they cannot have these things, but we tell them that we want them to have them rarely or at least very moderately, as these do have a diuretic effect, and we certainly don't want to lose any more fluids than we have to. Fluids that do contain electrolytes can be helpful during periods of diarrhea and vomiting. Patients who are able to even just keep down small sips of water, if they can keep down a few teaspoons of water every 30 minutes, if they can continue to keep taking down 5 to 10 milliliters of water, then they can stay hydrated throughout the day, but they have to be consistent and they have to continue to do that. Those electrolyte containing products can help, and we can talk about that. We mentioned coconut oil. Coconut water is a great natural electrolyte containing fluid, and that's a great product that doesn't have a lot of extra sugar, that can also be dehydrating for these patients. Patients receiving chemo and radiation may not feel that thirst, and so it's important for them to really be aware, cognizant of continuously taking in fluids. We will recommend to our patients that they keep a refillable water bottle with them, and be aware of how much fluid they're actually drinking throughout the day, because they just don't notice. They may be nauseated and not wanting to drink, and so they think they're getting enough, but in actuality, they're not. And in fact, dehydration can increase that nausea feeling as well. So we want to be aware of that. As far as nutrition goes, a well-balanced diet with plenty of carbohydrates and proteins are really going to get patients through this course of treatment. It's going to allow the body to have all of the building blocks that it needs to heal and repair healthy cells. Fruits and vegetables are a great source of high quality carbohydrates. We certainly recommend staying away from processed foods. If we can stay with some good, natural, healthy foods, that's best. Legumes, nuts, and seeds contain high quality proteins and actually tend to be better tolerated by the gut as opposed to animal type proteins when their gut is in distress. Many of the animal proteins can cause inflammation in the gut. And so using more plant-based high quality proteins is something that many areas are looking at and finding that's very helpful for patients. And again, it's better tolerated. Patients can eat smaller amounts more frequently. They can digest it more readily and easily and get a better use of the proteins that they can receive. Our patients work with dietitians that are specially trained in oncology, and they will go over all of this with our patients and help them come up with a plan specifically for them, specifically based on the type of treatment they're having, specifically on what their dietary needs are. And so that's very important. But I think the takeaway from all of this is that if we just encourage our patients to get those good carbohydrates, to get those good proteins, their bodies will be able to do what they need to do to help them heal and repair through the course of their treatment. Some tips that we provide for our patients, knowing that their taste may change depending on the type of treatment that they're receiving, whether it's radiation to the head and neck, or whether it's a type of chemotherapy that's affecting their taste, altering their taste buds. One of the things we say is that your favorite foods are not going to taste the same. We try and tell patients that as soon as that starts happening, it's best to stay away from those foods so that they don't then have an aversion to the foods once all the treatment's complete. We want them to have something to go back to that's going to bring them joy and happiness. And so we don't want them to create an aversion. So we'll tell them to start trying other things, figuring out what they can tolerate, what's palatable, and keeping in mind that this is going to all get better and those things are going to get back to normal. Your body's going to heal and repair, but it's important to just get through this point. If patients are nauseated many times, I know that all of us want to cook for those who are not feeling well. We want to feed them. It does something for us to help them feel better. But if we're cooking where those patients are, many times it makes them feel more nauseated and we can start a vomiting cycle. So we try and recommend that if someone wants to cook for the patient, that they can maybe cook somewhere where the patient in another home, somewhere close by. And that can help prevent a lot of the excess smell that can cause an increase in the nausea. Cool or room temperature foods tend to be well tolerated or better tolerated by patients who are experiencing nausea. So that's another tip we provide for patients. They just have to work with it and see what's helpful for them. And again, I really can't stress enough that those proteins, especially those plant-based proteins and the fluids are really essential for the body to repair and rebuild all of those normal healthy cells throughout the course of treatment. The damage that's done by the radiation to the cancer cells and to any abnormal cells is good. We want those to die off and go away, but we want our normal healthy cells to repair and rebuild. So this is where that comes into play, and this will help provide those building blocks to do that. So that's what we have for nutrition. What can I answer for you? What questions do you have about how we manage this? Oh, I see a question in the chat box about ginger and nausea, and I'm glad you brought that up, because ginger is a wonderful, wonderful option for treating nausea. Many patients find, and we recommend real ginger, not ginger candies or ginger ale, because ginger ale is mostly high fructose corn syrup. It's not helpful. There's not much actual ginger in it, if there is any, in most, at least here in the US. But ginger is a wonderful natural substance that does seem to show some benefit in many patients. We don't have a lot of studies in that. One study that we just did here in our institution actually is around peppermint oil and patients who are having nausea during chemotherapy. And we use peppermint oil on a cool washcloth and place that on the patient's neck while they're receiving chemotherapy or when they're having episodes of nausea. We actually found that patients had a really good response. It's something natural and simple that can be done for these patients, no side effects, and it's a wonderful benefit. They can do it as often as they want, and it works really well. Any other questions?
Thanks for the nice presentation over food and fluid during chemo and radiation therapy, because it's very important for normal tissue to heal after radiation and chemo. So fluid and proteins are very important.
Sir, can you allow me for one question to Emily?
Absolutely.
Yeah, thank you so much, Emily. So wanted to know about any modifications during the neutropenia phase of post-chemo, post-radiation. Do you have any issues about the fresh fruits, vegetables, salads, anything you stop that or you continue that?
So at least here, we use quite a few medications to help with neutropenia, and we don't see the issues that we used to. You know, when I've been doing this for over 20 years now, and when I started in this field, we did with fresh fruits and vegetables. We had to really be careful when patients were neutropenic. Now, our patients just receiving routine chemotherapy and radiation, we don't see those neutropenias. We're able to treat them if they do come up. So the only time we really deal with that on a regular basis has to do with our bone marrow transplant patients. And that's when we have more issues and we have to watch that. But then those patients can have cooked vegetables and fruits, and they do well with that, just so that they're cooked enough to kill off any bacteria or fungus that may be hanging out in those fresh fruits and vegetables.
Thank you so much.
Absolutely.
Thanks, Emily.
Thank you.
The next topic is care of central venous access, and this will be presented by Mary George.
So before Mary starts, I just want to introduce you to her, that she has been our teacher in Tata Hospital, Mumbai, and she was the probably first nurse who started the chemotherapy port insertion in Tata Hospital, Mumbai, and many of my colleagues have learned from her about the central venous access, and we are proud of her hard work. Currently, she is in US with her daughter, and she has agreed to deliver this talk and spare time for us for this early morning. Thank you so much, Mary sister. God bless you. Thank you.
Thank you, sir. Am I audible?
Yes,
Yes,
ma'am.
you are audible.
Good evening to everybody. I am Miss Mary George. I would like to share my experiences on care of central venous access devices, that is CVAD. What is CVAD? It is an indwelling device placed in the major veins of the body, that is in superior vena cava or inferior vena cava or atriocaval junction, that facilitates easy and long-term venous access for patient receiving aggressive anti-cancer treatment. What are the needs of CVAD? To treat immunocompromised patient stage, that is after aggressive chemotherapy patients and after bone marrow transplantation patients are going on a stage of anemia, thrombocytopenia, leukopenia. So we have to give more supportive care to this type of patients. And at the same time, we have to give different type of infusions. So we are in this time, it is a very important, this mandatory CVD has to be there to eliminate multiple needle pricks. That means we can analyze any blood sample we have to collect. Through this CVD, we can collect blood samples without any another prick, added prick. For the administration of recurrent and intensive therapies, so most of the therapies are antibiotics. We will look into that matter. Most of the drugs are highly alkaline, that is above 9 pH, highly acidic, that is below 5 pH. These drugs we should not give through a peripheral line. It will give rise to more complications. And again, for the infusion of vesicant drugs, more, as my previous presentation already, Ms. Lori explained about the vesicant drugs and the extravasation. So I am not explaining that much. So again, the long-term infusion of hyperosmolar solution like a total parenteral nutrition or partial parenteral nutrition. These all drugs are having hyperosmolarity. We should not give through a peripheral line. And the patients are having in a stage of septicemia, critically ill patients, after bone marrow transplantation patients or acute myeloid leukemia treatment patients are going very critical stage and septicemic condition. These patients also require different types of infusion at the same time. And again, the patients with poor vein status, especially for a pediatric or obese patient, we have to give long-term venous access. We have to search vein. It's very difficult. As a nurse, I know so much time, so many complications can also arise with the peripheral IV line. Whenever possible, place CVD as early as possible to avoid vein wastage. Here we can see different type of complications with peripheral IV cannulation. I am not explaining each and everything. Infusion phlebitis, hematoma due to multiple pricks, infiltration, extravasation with the dopamine, KCl, and in pediatric patients also ulceration and hematoma due to multiple pricks, and total parenteral nutrition we are giving through a peripheral line for a small child, so through a leg vein or scalp vein. This type of conditions can arise. So what are the types of CVD available today? At our Tata Memorial Hospital, we used different types of devices like tunneled catheters, that is Broviac and Hickman. These catheters are available single, double, and triple lumen. Hickman catheters, triple and treble lumen, we are mostly used for bone marrow transplantation patients. And implanted subcutaneous ports, that is also coming under tunneled group of catheter, we are using mostly for solid tumors, because once in a month or once in 21 days patients are coming chemotherapy, so no need of repeated pricks for this type of patient. Otherwise, we are putting hematological malignancy patients implanted subcutaneous port, we have to give multiple pricks. Then again, a patient needs a condition of thrombocytopenia, bleeding can occur. So we are avoiding mostly acute myeloid leukemia patients and all implantable subcutaneous ports. And non-tunneled group, valved and clamped peripherally inserted central catheters, that is PICC lines. That is we are using commonly at our Tata Memorial Hospital now. More than 90% of the patients we are using peripherally inserted central catheter, because This in catheters is insertion is very simple. Experienced certified nurse can insert at the bedside. No need of any anesthesia, no operation theater, and the patient can do all the daily activities. As compared to other type of devices, it is cost effective because anesthesia charges, theater charges, everything is less, and infection rate because it is keeping on the hand upper arm. So sweating, perspiration is very less. So infection rate also is very less. When we are taking care of the catheter, we can see. Then different types of devices in situ: Hickman catheter, hemoport, and pickline. This child pickline with the pickline, this is 7-month-old child. I inserted one pickline for this child. This child is having acute lymphoblastic leukemia, and 1.5 years we kept without any infection. It's a small child. So here nurses play an important role for taking care of any type of long-term devices. So it starts with pre-insertion counseling because it is a very important part, because with these catheters are keeping for long-term purpose, we have to give proper pre-insertion counseling to the patient and the relatives. While giving counseling, we are showing different types of photographs, dummies, different type of catheters, and explaining about the different types of catheters, parts of the catheter, how we are inserting, little anatomy of the vein, and site of the insertion, and what are the care after the insertion we have to continue, and what are the responsibilities we have to do. Everything we are explaining to the patient and the relatives. Actually, we are educating little bit, and we are taking informed consent from the patient and the family. Then pickline insertion nurses are doing, and other type of insertion we are referring to the doctors, and they are inserting the line. After the insertion, again our care is continuing prevention and solving of catheter-related problems and application of theory into practice. That is specific policies and procedures. We have to keep written materials in each and every ward, and we have to educate the patient, these nurses, other nursing practitioners, and we have to explain to them. They are in one hospital. We have to follow the policies and procedures in the same way for all the patients. So then so many advantages are there. We are following with the same protocol. And in our Tata Memorial Hospital, this care and maintenance we are doing, that is teaching and demonstration of dressing and flushing to the close relatives of the patient. And we are taking return demonstration from them till they are confident. And the dressing of the insertion site once in a week. Cleaning solution, we are using chlorhexidine 2%. And early detection and management of complications. Surveillance cultures of site, lumen, and peripheral blood within 24 hours of insertion. Further cultures are done if any signs of infection like fever, rigor, chills, anything, they are explaining. That time we are taking further cultures. Teaching of procedures to other medical personnel, and follow-up rehabilitation. And we are encouraging the patient and the relatives come to the clinic at the frequent intervals, and we are observing the site and encouraging the patient to interact with the other patient who is having same type of catheter. Ensure client satisfaction in CVD care and management is observed. And we are doing data collection from the day of insertion onwards till the removal of the catheter for the analysis of CVD related complications. And further changes also for the taken care and maintenance we are doing according to the analysis. Again, for tunneled catheters, for patency, that is the flushing, we are doing tunneled catheters, Hickman and Brovia catheters, we are doing once in a week, and port once in a month, and pickline also once in a week. But Hickman catheters, these all devices, Hickman, ports, or pickline, patients are admitted in the hospital for any type of infusion. Daily flushing is a mandatory. That is 10 ml to 20 ml normal saline is enough. If the patients are discharged from the hospital or catheters are not used, that time we are blocking with the 4 ml of heparinase saline, that is 10 units per ml for tunneled catheters, and subcutaneous port 10 ml of heparinase saline, that is 100 units per ml once in a month. For PICC line, we are using once in a week. Normal saline 10 ml is enough. But when we are giving blood transfusion or total parenteral nutrition, after finishing the blood products or total parenteral nutrition, we have to flush the catheter lumen with 20 ml of normal saline and change the blood set or transfusion set. And you attach new set with another infusion. That is mandatory. If we are collecting any blood sample through the catheter, soon after the collection, again we have to flush with 20 ml of normal saline. That is also mandatory. While doing flushing, we have to maintain positive pressure technique. That means clamped catheter we are flushing with 10 ml of normal saline. We have to take in the 10 ml syringe. While flushing 9 ml is finished, while pushing process, clamped catheter, while pushing process, we have to close the clamp. If in case we are using valved catheter for PICC line and all, after finishing 9 ml, we have to wait for 5 to 10 seconds, then remove the syringe. That is the positive pressure technique. Always we have to keep the thumb on the syringe plunger to maintain the pressure. Pulse flushing, when we are flushing, we have to push post method we have to do. 1 ml flush, then we have to post, then we have to flush. When the patients are coming to the hospital for any type of drug administration, first we have to flush with normal saline, then administration of drug, then saline, and again any drug we have to give, in between we have to flush with normal saline. We are not giving further treatment, we are closing and keeping the catheter, then heparinase saline is a must. PICC we can block and lock with the normal saline, and always you have to use 10 ml syringe for maintaining the pressure. For the prevention of CVD infections or any other type of complications, it starts before incision, during incision, and after the incision. Proceed care with IHI Institute of Healthcare Improvement Care Bundle. It included hand hygiene, maximum barrier precautions upon incision, chlorhexidine gluconide 2% skin antiseptic, selection of optimal site for CVC, and daily review of ongoing need for CVC with a transparent dressing. Some common risk factors are there. Catheter insertion with less than maximal barrier precautions. Heavy colonization of the skin. That means if normally all the patients or normal people are also having some colonization on the body, but we are not cleaning properly with chlorhexidine. That is vigorous cleaning. We are not doing, or patients are having any infected wound other than the PICC hand or anywhere in the body, touching that area and the patient himself touching the catheter, it can be give rise to colonization. Then contamination of the catheter hub. Before and after any type of injections we are giving, strict aseptic technique with the antiseptic solution cleaning is necessary. And increased frequency of catheter manipulation. If the catheters are used for any type of administration, once in 24 hours we have to open the catheter and flush the catheter lumen and change the IV set. And all the blood collections we have to do at the same time. If necessary, we can do any emergency, we can open the catheter. Otherwise, frequently we should not open the catheter for any simple work. And the nurse to patient ratio, and experienced nurses are less according to the patient ratio, it can also give rise to infection rate. And the type of device means we are not using proper material like a silicone or other long-term catheters we are using with the simple plastic or rubber. It can be give rise to infections. Then use of parenteral nutrition, or already nutrition is having a nice media for the growth of organism. So while giving parenteral nutrition also we have to be very careful. Patient characteristic also, then patients are according to the age, or patients are mentally irritated, they are not healthy. Sometimes they will go to the bathroom wetting the dressing. It will give rise to infection. Contaminated equipment, proper sterilization is a must. And poor catheter care and management. Even though we are taking care very carefully, some infectious and non-infectious complications can arise. Site infection, that is insertion site, in tunneled catheter, insertion site and exit sites are there. But for PICC line, only one side catheter is coming out or inserting the site. That site means in any infection within 2 centimeters of the site, any induration, redness, swelling, any discharge. With the transparent dressing, we can observe any suspected infection is there, we have to treat accordingly. Port pocket infection, already as previously we had seen, some infections or extravasation can happen on the port side. That also we have to observe very nicely. Then tunnel infection, more than 2 centimeters from the exit side along the tunnel, any induration, redness, swelling, pain is there, that is tunnel infection. This we have to treat with parenteral antibiotics, cultures we have to do, and within 24 to 48 hours, it is not reduced, we have to remove the catheter. Catheter colony or lumen infection, if any suspected infection, like patients are after flushing within half an hour to 1 hour interval, that patients are coming with a rigor, chills, any chest discomfort, anything they are complaining, we have to take the blood from the catheter lumen and the peripheral culture. Same time we have to take, and if the catheter culture positive with more than 3 times colony count than the peripheral blood culture, it may be lumen infection. Catheter related septicemia, both cultures are positive with same type of organism with same colony count, that is catheter related septicemia. We have to treat with specific antibiotics and daily dressing of the site, everything is mandatory. Phlebitis, after the insertion of devices, different type of phlebitis can come, that is mechanical phlebitis, septic phlebitis, chemical phlebitis, or thrombophlebitis. Mechanical phlebitis, because we are doing the insertion, powdered gloves should not use, we should not manipulate the catheter too much. Then catheter needle insertion, that we have to do smoothly, and proper fixation of the catheter, everything has to be there. Chemical phlebitis means because of the chemicals what we are giving, proper dilution is not there, and proper flushing is not there, then phlebitis can come. Septic means we are not taking properly, any organism is go, and it can be give rise to septic phlebitis. Then again thrombophlebitis, because after the insertion some thrombus will be there with the needle prick, that phlebitis can give rise to phlebitis. Everything has to be treated accordingly, and soon after the insertion, within 3 to 2-3 days, within 2-3 days of insertion, any redness, swelling starts, then and there we have to treat with local application of thrombogel ointment, and afterwards glycerin maxillary compressions also we can give. Then block, that is the common thing that I will explain. Fracture, malposition, dislodgement, accidental expulsion. These all things are non-infectious complications. And occlusion, that is block, risk factors are there, that abnormal clotting times, if a patients are having. Then solutions high in calcium and lipids, that also give rise to occlusion. Incompatible drugs, we are not doing in between proper saline flushing, it can be give rise to blockage. Then handling by untrained staff. For the exact causes, we will tell poor flush technique. We are not doing proper flushing. In between any drug we are giving, we don't know what drug is precipitate with the other drug. So saline flushing is mandatory. Then insoluble or incompatible drugs we are giving, that time also occlusion can happen. Then fibrin sheath. Soon after the insertion, fibrin sheath, especially for open-end catheter like a Hickman, subcutaneous port, fibrin sheath is coming at the tip, like acting like a valve. When we are pushing injection, it will go. When we are aspirating, it will close, like with that fibrin valve. It can be partial or complete. So that also we have to treat according to that. We have to proper flushing, saline flushing, 20, 30, 40 ml sometimes we have to do. That is very nicely we have to flush with a little bit pressure, force and flush we have to do. Then poor securement of the catheter. Sometimes if you are not doing proper securement, then catheter will get twisting or pinching of the catheter can happen. So in clinical intervention, what we have to do, check for any mechanical obstructions are there or not. Clamp is closed while pushing, clamp is open or not. Pinching is there or not, we have to check it. Twisting is there or not, everything we have to check it. Then afterwards we have to do, if any these mechanical obstructions are not there, we have to take 10 ml syringe, gently aspirate and gentle push with normal saline. Then if it is not successful for 3-4 times we are doing, then initiate with the urokinase 5,000 to 10,000 international unit. That is also we have to see the patient's platelet count, minimum 20,000 should be there, and you have to inform the unit doctors. And whenever we are giving this urokinase, we should not push inside the patient's body, only inside the lumen. We have to aspirate, push gently, aspirate, push gently. That we have to continue for 10 minutes, 20 minutes, and wait for 30 minutes. Again, we have to continue next day after 24 hours. Like that we can do. And most of the fibrin and other clots also can remove. If it is not removed, then we have to remove the catheter. Some don'ts are there. Don't remove the catheter in severe neutropenic condition with fever or in severe septicemia. Don't use catheter if any type of suspected infection. That time we have to close the catheter lumen for 48 to 72 hours and observe. After the observation, the fever is reduced and no signs of infection. That means that catheter is not having infection. That you can evaluate like that. Don't handle CVD without proper knowledge, training, and experience in insertion and care and maintenance. Catheter removal is done after completion of treatment. If infectious or non-infectious complication or not resolve this any complication within 48 to 72 hours. And a positive culture with continuous high-grade fever. Some patients are getting like that. That time we have to remove the catheter. Or patient's preference and patient's death. PICC insertion is done by certified nurses. CVD-related complications can be managed efficiently and effectively by trained nurses. PICC has low infection rate as compared to other type of tunneled catheters. I already explained it is cost effective, and the daily activities of life can be maintained with all type of central venous access devices. Self-body image is maintained with subcutaneous port. Overall, I concluded early assessment and proper selection of device is mandatory. Experienced and certified personnel is required for the pre-insertion counseling and insertion. Strict aseptic care and maintenance is reduces infectious and other non-infectious complications. A CVD nurse instills confidence in the patient and relatives during a time in their life with cancer, empowering with more autonomy in their daily activities. It automatically improves the patient's quality of life. Thank you for your attention.
Yeah. Thank you, Sister Mary, for very nicely presenting all aspects of central venous catheters and complications, how to take samples, how to prevent infections. So very nice presentation. And we move to the next speaker, and that is Julia Chalinor from US, and she will be discussing on role of nurse in pediatric cancer patients management.
So before Julia speaks, may I request Kavita to please keep your question in the chat box, or we can discuss during the panel discussion. In the interest of time, we will not be allowing too many questions presently. We will discuss and we will pull on the panel discussion a little longer. And before Julia starts, let me introduce her that she is very senior pediatric oncology nurse, and she has vast experience of the Indian circumstances also. She had worked in Rajiv Gandhi Cancer Hospital for I think more than 7 years, and I had a meeting with her during the SIOP meeting in Abu Dhabi, and she has hardcore interest for the pediatric oncology. Very well experienced, very well trained and experienced with the Indian circumstances. With these few words, Julia, over to you, please.
Afternoon. My name is Julia Challenor. I'm a pediatric oncology nurse, the Secretary General of the International Society of Pediatric Oncology, and an associate adjunct professor of nursing at the University of California, San Francisco in the US. It's a pleasure to be with you here today to discuss advances in oncology nursing practice and cancer treatment. I've been asked today and tasked with describing the role of the nurse in pediatric cancer management. And I thought I would open with the US-based Association of Pediatric Hematology Oncology Nurses, APHON, 2014 Scope of Pediatric Oncology Nursing Practice Guidelines. The first standard is about assessment and requires that the nurse assesses the child's physical, psychosocial, cultural, and spiritual needs for an appropriate plan of care. Number two is diagnosis. This is nursing diagnosis to identify the problems and determine appropriate interventions, expected outcomes, plans, and evaluation. The third is outcomes identification, to work with the family and child to meet the mutual goals of care. Expected outcomes means adequate education, optimal growth and development, optimal physical and emotional health, minimal symptom distress, prevention of toxicity or chronic complications, and early detection and screening for cancer reoccurrence or second malignancies, which is a serious concern in childhood cancer. Standards 4 is planning, guides the healthcare team to implement evidence-based interventions that facilitate the achievement of expected outcomes. 5 is implementation of nursing action to prevent and treat healthcare problems associated with the diagnosis of cancer or blood disorder. The overall goal is to improve the child's health status, promote quality of life, and facilitate optimal family functioning across the care continuum. 5A is coordination of care in a variety of settings, necessitates communication and coordination among settings to provide quality of care. Health teaching and health promotion provide daily education to promote, maintain, restore, and improve the health and comfort of the child with cancer or a blood disorder, all nursing considerations. I'm not going to discuss standards 5, C, D, and E because these relate to advanced practice nurses, a specific role in the United States. But standard 6 is evaluation of interventions for the patient, ethics related to nursing care, education, for example, nursing continuing education, and 9 is evidence-based practice and research. Standard 10 refers to the quality of nursing practice. 11, again, communication with other members of the healthcare team, patients, and families using strategies to contribute to a positive working environment through responsible professional behavior. 12 is leadership, demonstrates leadership skills, as nurses do, necessary to promote nursing care delivered to children and families, and the profession of pediatric hematology oncology nursing. 13 is collaboration and refers to the coordinated and ongoing interaction between the child and family and the multidisciplinary team. Professional practice evaluation includes self-evaluation as well as peer and supervisory input in accordance with current professional nursing standards. And finally, standards 15 and 16. 15 is resource utilization. The nurse delivers safe, effective care and utilizes resources efficiently. The nurse's clinical and administrative decisions consider available resources and desired outcomes of care and reflect the ability to prioritize actions and utilize colleagues to achieve desired patient outcomes. And finally, environmental health promotes a practice environment that reduces environmental health risks for patients, families, and clinical and non-clinical staff. Nurses comply with all national, state, regulatory, and specialty practice guidelines. This has given you some idea of the breadth and scope of nursing practice for pediatric oncology nurses across the United States, and I think many apply to nursing of children with cancer and childhood cancer care across the world. I'd say the number one goal for pediatric oncology nurses is to anticipate potential treatment complications. We are dealing with children from newborns all the way through late adolescence, and in some cases, young adults. You need to know your patient's age and stage of development. What are the implications for nursing care and treatment? What are the implications for your interactions with the patient's parents or caregivers? You need to know the medications and treatment the child is receiving during the treatment. What are the potential side effects? What is the nursing care to prevent or reduce those side effects? What do you need to teach the patient about these drugs and treatments? And what do you need to teach the parents and caregivers about these drugs and treatments? This is much to cover. Therefore, I'm going to pick out a couple of highlights, just talking about 2 drugs, chemotherapies right now, to give examples. So chemotherapy-related complications can include the side effects of, for example, vincristine or vinblastine given by IV, which can include high blood pressure or hypertension, feeling tired, alopecia, myelosuppression, tumor pain, but most importantly for the nurse and most worrisome, I think in general, are neuropathologies as signs of major toxicity. That would include constipation, bone and jaw pain, and foot drop. A second example is of a chemotherapy-related complications are the side effects of methotrexate, a quite common drug we use in pediatric oncology, given by mouth, IV, injection, or into the spinal canal, and can include blood clots or thromboses, pericardial effusion, pericarditis, neurotoxicity, dizziness, tiredness, headache, alopecia, acne, rash, ulcers, itchiness, inflammation of the bowel, enteritis, bleeding, nausea, vomiting, and inflammation of the mouth or mucositis. Here I pause because mucositis, which is extremely distressing to children, especially very young children, and can lead to infection, and the patient will need morphine just to eat in some cases. If mucositis occurs, then the child's entire GI system is affected with negative consequences and requires specific nursing attention. Another high priority is to avoid liver failure and cirrhosis of the liver, and that's why we're monitoring liver enzymes. I won't go through the rest of this complications because you can see them on the right, but methotrexate has a long list of potential complications the nurse must be aware of and vigilant for. Extravasation in pediatrics. I recognize that you've either had or are going to have a talk on extravasation in general by my colleague, Lori Buswell. However, I want to mention in pediatrics what makes extravasation particularly risky. For children, maintaining a peripheral IV or receiving a vincristine push can be at risk of extravasation, for example. Children are active, they're not always cooperative. Their play is quite physical and they're running around and they're waving their arms. This makes it difficult to maintain a patent IV and to even start an IV. So understanding the difference between an irritant and a vesicant is critical. Vesicants can cause permanent damage, severe burns, and even amputations. Drugs that can result in tissue necrosis or formation of blisters when accidentally infused into tissue surrounding a vein are the description of a vesicant. Here I list pediatric oncology chemotherapy that is used commonly and can be, are vesicants and can be of quite high risk for nurses administering these drugs to be vigilant about extravasation, including actinomycin D, dactinomycin, daunorubicin, doxorubicin, epirubicin, idarubicin, mitomycin C, vinblastine, vindacin, vincristine, and vinorelbin. Vigilant nursing care and skills diminish the risk of extravasation for children receiving chemotherapy. Another alternative and good intervention to avoid extravasations is nursing education. I give you an example of a nursing educational intervention study in Turkey, a recent study in 2020 that was published in the Journal of Pediatric Research. The content of the educational intervention included descriptions of pediatric infiltration and extravasation, risk factors and symptoms, medications and fluid lists that have a greater risk for infiltration and extravasation, scales of infiltration and extravasation, and nursing initiations addressing the prevention and management of infiltration and extravasation, special antidotes, and subjects concerning wound care. The preparation was based on current literature, and the subject was given as a lecture. An algorithm was prepared and printed as a poster and posted in the treatment rooms of children's clinics. Before the education program, the knowledge mean score of the nurses was 9.4 plus or minus 3.22, minimum 0, maximum 17. And after the education program, it rose to 12.13 plus or minus 1.58, minimum 8, maximum 16. The increase in knowledge levels stimulated by the educational intervention was statistically significant at p less than 0.001. This was a visual of the results of this intervention. On the left is the knowledge level of the nurses, and you could see pre-intervention and the increase in knowledge post-education. On the right is the extravasation infiltration rates, which you can see on the left pre-education and the significant reduction post-education. I switch now to fever and neutropenia in pediatric hemato-oncology. Kids play even when they are very sick and may not look or behave as if they have a fever. Knowing ahead of time when a patient is at risk of a fever is critical. I present a short case example. Ayushi is 6 years old. She has ALL and is receiving induction therapy. The nurse takes her temperature at night and she has a fever of 38.1. The nurse is 1 hour from leaving his shift and has 7 other patients to finish care for before leaving. He forgets to call the doctor on the night shift to advise him of Ayushi's fever. The day nurse goes to take Ayushi's temperature 2 hours later because she had to receive reports, so she was delayed. By the time the day nurse sees Ayushi, she is in shock and non-responsive and has to be transferred to the ICU. This is a slide to give you an idea how fast a fever can turn into a very critical and serious situation. On the left, you'll see the time in hours in column 1, the organisms per ml in the center column, and clinical manifestations in the right column. So if you start with time 0 and 1 organism per milliliter, there are no clinical manifestations. By the time you get to 6 hours later, there are over 4,000 organisms per ml and the child has a fever. By the time you get to 8 hours later, you have sepsis, 10 is septic shock, and 12 is death. If you look at the triangle on the right, you'll see febrile neutropenia. This is for children who are neutropenic. You start with a bacteremia. 2 hours later, you have septicemia. 2 hours later, septic shock, and 2 hours later, you'll have death. So you really have there a 6-hour window. And this is important for nurses to understand when they take care of children with cancer who are neutropenic. This is an algorithm from my hospital. It's the pediatric oncology and bone marrow transplant patients with fever, initial inpatient management. This is just an example. The goal is to administer first antibiotic dose within 60 minutes for neutropenic and or clinically unstable patients, or in other words, what we often call the golden hour. And this is why we are constantly counseling parents that if that child has a fever, they must come immediately to the hospital. I want to discuss now survivorship, because we all hope when the children are first diagnosed, our goal is and we hope for survivorship. And in fact, National Cancer Survivors Day is on June 6th this year. Children respond better to cancer treatment in general than adults. They are more resilient physiologically. They have less comorbidities, for example, high blood pressure, diabetes. They have less negative lifestyles. They generally do not smoke or drink alcohol. Higher survival rates than adults are generally believed to be related to, among other things, clinical trials, because more children are treated in clinical trials in general than adults. However, survivors of childhood cancer often live many years with secondary sequelae of their treatment and a higher risk of second cancer. They often miss significant schooling during treatment, which makes adult employment and careers challenging. Stigma related to being a cancer survivor, including potential infertility for some diagnoses, can affect marriage, employment opportunities, and adult quality of life. These are important outcomes for pediatric oncology nurses to be aware of, even during treatment, and preparing children and families for this after survivorship and during survivorship. Fortunately, in India, there's Kids Can Connect. This is a group, and I've given you the URL. It's a childhood cancer, teenage, and young adult survivor group under the Can Kids, Kids Can group in Delhi. Cancer patient survivors, siblings, peers, and young volunteers can be part of this group. A capacity building platform creating a pool of career-enhanced professionals who have successfully reintegrated back into society make up this group. Survivors turned cancer ambassadors advocating for cancer in their own capacity and career stream are active within Kids Can Connect. Kids Can Connect are currently running a 2-year internship-based fellowship model for survivors, and that may be worth looking into for any of you who are caring for children or adolescents or young adults who've survived childhood cancer. Sometimes there is end-of-life care required, and I'm sorry that the logo here has blocked the title of the slide, but I'm going to discuss here end-of-life care, and this is an e-learning that's free program. The International Children's Palliative Care Network is quite well regarded around the world. It has these programs. The modules include Introduction to Children's Palliative Care, Pain Assessment, Child Development and Play during Palliative Care, Communication and Emotional Issues, Grief and Bereavement, which I think is very important for us as nurses to be aware of and have the skills for in dealing with families and the patient when cure is no longer possible. Finally, a second resource for you called Together. This was created by St. Jude Children's Research Hospital in the United States. Above the red line are the different links that you can go to about pediatric cancer, diagnosis and treatment, care and support for families, life after cancer, and teens and 20s. I've given you the URL. It's an excellent resource for your making teaching materials to work with family, patients and family education, and also for new nurses who are onboarding. On the right is an example of the landing page. It's so large I couldn't fit it all on the slide, but it will give you an idea of the plethora of information available for you for free. So in summary, a pediatric oncology nurse, aside from being the best kind of oncology nurse, in my personal opinion, because I love pediatrics, is to be a bedside clinician, knowledgeable about childhood cancer disease, treatment, survivorship, and end-of-life care, who delivers appropriate nursing care throughout the child and family's cancer journey. An advocate for patients' families' rights and health within hospitals and governments and the public area. Also, for a productive and a safe work environment to advocate for that in your hospital or clinic or setting. A supervisor and leader who builds trust with the patient and family, provides mentorship to new nurses, and a teacher who educates patients and families, the public, and local, national, regional, and international stakeholders about the challenges, barriers, successes, and benefit of excellent pediatric oncology child treatment. Please keep the nursing light of Florence Nightingale burning for your pediatric patients with cancer and their families, and join me and our colleagues across the world giving care for these super important patients. Thank you.
Thanks, Julia, for nicely presenting the aspects of pediatric cancer patients' care. And
Can I go ahead and start?
Yeah, definitely.
Okay.
Yes.
Alrighty. Okay. I'm going to share my screen to pull up my slides. Good morning or good afternoon, I guess, in your case. I'm Tiffany Richards. I'm a nurse practitioner at MD Anderson Cancer Center in the Department of Lymphoma and Myeloma. I'd like to thank the organizing committee for inviting me to come and speak with you today on prevention and treatment of neutropenia and infection. So the mainstays of infection prevention, as we all know, is good hand washing. We know that good hand washing is the #1 way to help prevent infection. Additionally, ensuring that nurses as well as patients and their family members are using sterile technique when changing central line dressings, to use clean technique when flushing lines, instruct patients on avoiding people who are sick, the use of growth factors, and then also ensuring that patients know when to come to the hospital with any signs and symptoms of infection. If we look at prevention of infection, the NCCN here in the United States has recommendations as far as antibiotic prophylaxis. And they divide it into 3 categories: those patients with solid tumors, those with a hematologic malignancy, and those with acute leukemia. So for patients with solid tumors, if they have anticipated neutropenia less than 7 days, then no prophylaxis is recommended unless they have a prior history of herpes simplex virus. And then they recommend viral prophylaxis. If they are anticipated to have neutropenia that lasts anywhere from 7 to 10 days, then it is recommended that they be placed on bacterial and fungal prophylaxis during their period of neutropenia, as well as viral prophylaxis. PGP prophylaxis is recommended as well if their neutropenia is anticipated to last more than 10 days. For the hematologic malignancies, such as myeloma, CLL, and lymphoma, bacterial and fungal prophylaxis is recommended during any anticipated neutropenia. And the reason for that is because their white blood cells and their immune system is affected by the cancer, they're going to be even more susceptible to infection, as well as myeloma patients are going to have hypogammaglobulinemia, which is also going to place them at risk for infection. It's also recommended that they be placed on PJP prophylaxis if their anticipated neutropenia is going to be greater than 10 days. And those patients with acute leukemia, bacterial, fungal, viral, and PJP prophylaxis is recommended at all times. If we look at emerging therapies, such as the monoclonal antibodies, we can see that the NCCN has come up with recommendations with each of the monoclonal antibodies. So for example, for those patients with CLL or lymphoma, if they're going to be on a CD20 monoclonal antibody, it is recommended that they be placed on acyclovir or valcyclovir prophylaxis. Additionally, patients should be screened for hepatitis B because these monoclonal antibodies can place patients at risk for hepatitis B reactivation. And so this is just a nice little chart that you can refer to as far as other prophylaxis for the more targeted therapies. For checkpoint inhibitors, there's also recommendations with drugs such as nivolumab, pembrolizumab. They only recommend PJP prophylaxis if they are going to be on high-dose steroids, more than 20 milligrams per day of prednisone for more than 10 weeks. Additionally, they are recommending that we screen for hepatitis B prior to starting because of the risk of hepatitis B reactivation. This just kind of goes over the guidelines as far as prevention of hepatitis B and HIV reactivation. So patients should be screened for hepatitis B, hepatitis C, and HIV prior to starting immunosuppressive therapy. If they're hepatitis B positive or hepatitis C positive, you want to make sure that you do viral loads, as well as consult infectious disease or a liver expert. Oftentimes, if they are hepatitis B positive, but they don't have a viral load, they will be placed on entecavir as prophylaxis while they are on therapy. If they are hepatitis C positive and they have a positive viral load, then they will be placed on concomitant or sequential anti-hepatitis C while they are undergoing treatment for their cancer. If they're HIV positive, we want to make sure that we're consulting an infectious disease who's an expert in HIV to determine the appropriate antiretroviral therapy while they are undergoing chemotherapy. Another way to help prevent infection is obviously going to be making sure that patients are placed on, receive their vaccines. And so particularly for patients who undergo an autologous stem cell transplant, they do have to receive all of their immunizations over again. So they will have to receive their DTaP anywhere from 6 to 12 months after transplant, and they will have to get all 3 doses over again. Same with Haemophilus B, hepatitis B, inactivated polio vaccine, and recombinant zoster vaccine as well. Now, for those patients who will need their MMR, it's really important that they are more than 2 years out from their therapy and that they are not on any immunosuppressive therapy and that they do not have any evidence of graft versus host if they had an allogeneic transplant. Additionally, you want to make sure that you're checking antibody titers because you should only re-immunize with MMR if they are seronegative. Now, for the heme malignancies, oftentimes patients don't get revaccinated with MMR because it is a live vaccine. So they may be at risk for having to actually getting it. Additionally, patients who have young children or who are around their grandchildren, for those patients with heme malignancies, I work in multiple myeloma, and so we do instruct our patients to avoid being around their grandchildren for about 6 weeks after when they receive their live vaccine. And then obviously, with the current pandemic, the COVID vaccine is going to be important for cancer patients. So what about the use of growth factors? So we want to first assess their febrile neutropenia risk. So does their chemo regimen have a less than 10%? Is it intermediate, meaning 10 to 20% risk of febrile neutropenia, or high risk, 20% or more? And then we also are going to look at patient risk factors such as have they had prior chemo radiation? Do they have persistent neutropenia? Do they have bone marrow involvement by tumor? And do they have recent surgeries or wounds? And then we're also going to look at do they have a history of prior neutropenic fever, because that's also going to influence whether growth factors are appropriate or not. So what are some risk factors for febrile neutropenia? So we know that patients with an advanced stage of cancer who've had prior neutropenia and who have primary of breast, lung, colon, or ovarian, or who have a hematologic malignancy are going to be at more risk of developing febrile neutropenia. If they have a more chemo-intense chemo regimen, they're going to be at more risk. If they're on immunosuppressive medications, if they're receiving treatment with curative intent, if they're also getting concurrent radiation or more myelosuppressive chemo regimens. And then we also have individual risk factors. We know that older patients are more at risk, females are more at risk if they have open wounds or pre-existing infection, if they have a decreased absolute neutrophil count at the start of the cycle. So not necessarily with an ANC less than 1, but they may just be leukopenic. Do they have renal or hepatic dysfunction, their performance status? And then obviously those patients who have poor nutritional status are also going to be more at risk of developing febrile neutropenia. So what do we want to make sure that we do if somebody comes in with neutropenic fever? So as nurses, while we may not be ordering these tests, we want to make sure that the appropriate tests are ordered and then reach out to the physician if we see something that maybe hasn't been ordered. So we want to, first of all, get blood cultures, and we want to get blood cultures immediately. We want to get from a peripheral stick and then one blood culture from a central line if they have one present. We want to make sure that we get urine cultures, if they are having diarrhea, to get a stool specimen. And then if they are having respiratory symptoms, that we're getting a COVID swab as well as influenza. We want to make sure that we're looking at their labs, so checking a CBC, getting a lactic acid, a comprehensive metabolic profile, and then also obtaining a chest X-ray to look for any evidence of pneumonia. So what are some considerations as far as antibiotic choice? So one is going to be recent culture results. So have they had a recent infection? What antibiotics were they on? Do they have a history of multi-drug resistant organisms? Do they have a suspected line infection? So are they presenting with chills, rigors? Do they have an infusion catheter, cellulitis, or drainage around an exiting line? What prophylaxis are they on for antibiotic? Because if they're on, for example, ciprofloxacin, then you definitely may not want to use a fluoroquinolone. You may have a different preference as far as what type of antibiotic regimen is going to be the patient's going to be on. What is the potential source of infection? What are their drug allergies? What about organ dysfunction? We want to make sure that we're looking at their renal and hepatic function. And then also, do they have mucositis? And so this is our algorithm at MD Anderson if patient comes in with neutropenic fever and they have a hematologic malignancy. So if they have neutropenic fever, they are placed on cefepime and usually as well as vancomycin. If they have a suspected line infection or if they have bacteremia, we're either going to use cefepime, Zosyn, or meropenem, as well as vanco or dapto. And then if we need double gram-negative coverage, we may add ciprofloxacin and amikacin. If they are positive for MRSA colonization, or if they have mucositis, then very similar regimens. And then if they have a documented beta-lactam allergy, then we may, for neutropenic fever, start them on aztreonam, as well as either amikacin or ciprofloxacin, as well as vancomycin and linezolid. And so based on where you suspect what type of infection they may have is going to guide the antibiotic choice for patients. And then for those patients who have solid tumors, it's a little bit differently. So if they do not have a beta-lactam allergy, then we would start them just on cefepime. Whereas if they have mucositis, or if you have a suspected intra-abdominal infection, you may put them on Flagyl as well. If they have a documented beta-lactam allergy, then we would use aztreonam as well as ciprofloxacin, and then potentially vancomycin as well. And so really, you're really going to got your antibiotic choice is going to be guided by what type of malignancy do they have, what are their allergies, and then what do you suspect is the potential source of their infection. Now, obviously, whenever somebody comes in with neutropenic fever, it's going to be important that we're assessing for any signs and symptoms of sepsis. And so there are some risk factors for sepsis. So diabetics, if they're obese, if they're over the age of 65, if they are admitted to the ICU, if they're neutropenic, and then if they are on immunosuppressive medications. Now, as nurses, it's really important that we understand what are the clinical manifestations of sepsis so that we can potentially identify these patients early. So one is we're going to be looking for signs of infection around a specific source. So do they have a line? Do they have drainage? Do they have a peritoneal dialysis catheter? Are they malaise? Are they having more fatigue? Do they have hypotension? So if their systolic blood pressure is less than 90. If their temperature is greater than 38.3 or Celsius or less than 36 degrees Celsius. Is their heart rate greater than 90? Are there tachypnic with respiratory rates greater than 20? Do they have signs of end organ perfusion? So early signs are going to be flushed, warm skin, and then late signs in shock are going to be pallor, cool to touch, mottling, and then decreased capillary refill. What is their mental status? Like, are they altered? Are they obtunded? Are they restless? And what about their urine output? Are they producing urine, or they have decreased urine output? And then do they have an ileus or absent bowel sounds? And so if they have any of those, that's really gonna really raise some concern as far as that this patient could be becoming septic. And so we need to be making sure that we're assessing our patients appropriately. So making sure that we're evaluating for any abnormal breath sounds. Do they have a cough? Are they exhibiting any abdominal tenderness or guarding? Are they having diarrhea? Do they have any, we're making sure that we're looking in their oral cavity for signs of ulcers and thrush. We're looking at their skin integrity, making sure that they don't have any skin breakdown. Do they have a catheter in place? Is there any tenderness or redness anywhere? I had a patient once in clinic who presented with some just erythema to the leg. And within 4 hours, the cellulitis had spread to encompass like all the way up and down the thigh. And so the skin infection really dramatically increased in a very, very short time. And so we need to make sure that we're looking for any signs and symptoms and identifying these early in the process. So what can we expect in our lab? So if their lactic acid is greater than 2, we're going to be concerned about organ dysfunction. And if their lactic acid is greater than 4, we're going to be concerned that the patient is at risk for septic shock. We can see leukocytosis with a white blood cell count greater than 12,000, as well as leukopenia with less than 4,000 white blood cell count. They may develop thrombocytopenia. Their C-reactive protein may be high. Their creatinine may be going up due to organ dysfunction. They may start to have liver dysfunction, and you may see a bilirubin greater than 4. Their coags may start to increase, and so we may see an INR greater than 1.5. And then because they may be becoming more acidotic, their bicarb starts to drop. So what are some nursing interventions for sepsis? So the biggest thing is going to be early identification of signs and symptoms of sepsis. And then we want to make sure that we're initiating antibiotic therapy immediately. We really ideally want to begin IV antibiotics within 30 minutes of the fever being started and antibiotics being ordered. Making sure that we have supportive care measures. So making sure that we have access to IV fluid boluses in case the patient would start to drop their blood pressure. Making sure that we're doing a focused head-to-toe assessment and monitoring their vital signs frequently. So if somebody comes in with neutropenic fever, we want to be monitoring their vital signs more closely within the first few hours upon arrival to make sure that we catch any early signs of sepsis. We want to make sure that we're using supplemental oxygen to keep their oxygen saturation greater than 92%, that we're drawing labs and bulk cultures immediately. We want to make sure that we're monitoring their I's and O's and identifying any decreased urine output. Making sure, as I mentioned, that we have IV fluids available to do prompt fluid resuscitation if needed. And then what are your institutional policies is important. And then we need to make sure as nurses that we're educating patients and family on the importance of prompt identification of infection, right? So we need to make sure that they understand what are the signs and symptoms of infection and why it's important that they come to the hospital. That it's not just enough saying, okay, come to the emergency room if you have a temperature greater than 38 degrees. And so we need to make sure that they understand the why so that they actually will come. We want to make sure that they're aware of the signs and symptoms of sepsis. So I always tell my patients, not just monitoring for temperature, but if they get shaking chills, that they just need to come to the emergency room without calling, that they just need to come. Are they becoming pale or discolored skin? Are they becoming more sleepy, confused? Are they short of breath? And then making sure that patients and family understand the importance of good hand washing and hygiene, that they stay up to date on their vaccinations, that they know how to properly care for their central lines, and if they have any wounds, that they know how to use that and how to do septic technique. That they are educated about their immune compromised state, that they understand why they're going to be more at risk for infection, and then the importance of prompt notification of new symptoms. And so I just want to present this case. So this is a 65-year-old woman with a history of large cell lymphoma who is presented on cycle 4, day 7 of R-CHOP, and with the adriamycin being given over a 48-hour continuous infusion. She received growth factor support with pegfilgrastim on day 3 of therapy, and she presents to clinic with a temperature of 38.3 and an ANC less than 0.5. She denies chills, but notes she's very tired and weak. She reports mouth pain, and on exam, she has ulcerations in the oral mucosa. She has no known drug allergies. And so the question is what lab should be ordered next? So we ordered a CBC, and we found that her platelets were 35,000. She was anemic with a hemoglobin of 9.8. She was neutropenic with an ANC of 0.5. She did have some degree of renal dysfunction with her creatinine at 1.5. Her CO2 was 17, and her lactic acid was 3.1. So we are seeing some early signs of sepsis with the lactic acid greater than 2, and her CO2 is borderline, and she is having an increase in her creatinine. Blood cultures, both from her peripheral and her central line, were drawn. Urine culture was performed, a chest x-ray, a COVID swab, and oral mucosa swab because she has the most ulcerations was done. She gets to the floor, she started on IV antibiotics, she developed systolic hypotension and a heart rate of 120. And so obviously she's starting to drop her blood pressure, her heart rate's going up. And so we suspect that she may be she's starting to become septic. She's given IV fluid bolus without improvement of her blood pressure, and she's transferred to the ICU for further management and was started on vasopressors. And so again, making sure that as nurses that we're identifying these patients early and then promptly doing our nursing interventions. So in conclusion, it's important to identify patients who are going to be at risk for infection, that we administer growth factor support as recommended, ensure prophylactic antibiotics are ordered, prompt identification of fever or signs and symptoms of infections important, that we initiate antibiotics immediately within 30 to 60 minutes of onset of neutropenic fever, that we're assessing for early signs and symptoms of sepsis, and that we're educating patients and their families on signs of infection and sepsis. Thank you very much.
All right, Chico.
Thank you so much, Tiffany, for excellent talk. In fact, it was very good, very informative, and not only for the nurses, but for doctors also. This is very good learning lessons. You have taught us various signs and symptoms of sepsis and how fast we can act. So really very good. And we will be requesting you if you can spare some time for panel discussion. Also, we will appreciate your inputs at the time of panel discussion.
Okay.
Thank you so much. So with this, we move to the next session. And may I request our chairperson, Professor G.S. Bhati. He is senior professor and head in the Department of Medical Oncology at SN Medical College, Jodhpur. Thank you, Bhati sir, for accepting our invite. Along with him, Dr. R.K. Tamar. He is professor and head in the Department of Radiation Oncology at Government Medical College, Kota. Thank you, Dr. Tamar, for being with us, and Dr. Deepak Shukla, a senior consultant medical oncology at Manipal Hospital. With this kind introduction, may I request Dr. Bhati sir to start the next session, please. Next slide, please.
Sister Ellen Thomlis from the United Kingdom, and she is the consultant nurse and from the University Hospital of Southampton NHS Foundation Trust UK, and she will speak on nurses' role and the responsibility in immunotherapy. Ellen Thomlin.
Thank you. I'm just going to share my screen. Can you hear me okay?
Yes, you are audible.
Thank you. Am I on the first screen? Yes. Thank you very much for that kind introduction and for the invitation to talk to you today. I'm based in the UK. It's just after lunchtime here, and I hope you're enjoying your study day. So I was asked to talk about the nurse's role and responsibilities with regards to immunotherapy. I currently work at the Royal Marsden Hospital, which some of you may have heard of in London. These are our two campuses, the top one in Chelsea in central London, and the bottom one in the outskirts of London in a place called Sutton. So in terms of giving this overview talk, I wanted to really point out that I think nursing roles are throughout the pathway of a patient who is receiving immunotherapy. So a particular passion of mine is the education pre-treatment. There's obviously education and input of the nurses in the administration rooms. We need to manage side effects, and we need to support the patients throughout. So in order to illustrate that, I'm just going to do an overview of immuno-oncology, how nurses are vital to that pathway, and offer two case histories, which are poles apart really in terms of their severity. So I hope that's okay with everybody. So firstly, immunotherapy is an umbrella term for lots of approaches to drugs. So I am going to talk about the checkpoint inhibitors. I'm not going to talk about CAR T cells, monoclonal antibodies, or the vaccines, which are different in the approach. So today we're talking about checkpoint inhibitors. So in terms of how they work and how they fit into the treatment pathway, checkpoint inhibitors operate by binding to these key checkpoints, which have only really been discovered in the last 20 years. And the scientists have been working on trying to develop the drugs that actually allow this point in the cell cycle to develop the therapies that can attack the cancer. So we have had for many years, of course, the chemotherapy and the cytotoxic drugs that do this, but they have a very crude approach. They go in, they cause disruption to the cell, and have very, very different ways of causing that cell to die or to commit suicide. And then in the last 10 years, of course, we've had the targeted therapies, which look to find a receptor or lock on to something, perhaps on the cell surface, or perhaps internally within the cell, perhaps a strand of DNA or a genetic mutation. And those have been used in combination for treating cancer for a while now. But the new kid on the block and the new speciality is immunotherapy, and particularly we're going to talk about checkpoint inhibitors, and we're looking for the immune system to actually modulate itself and attack the cancer. So recognizing non-self as a way to cause cell cancer death. So in terms of the checkpoint inhibitors, we have three distinct groups currently: the anti-CTL4, the anti-PD1, and the anti-PDL1. So they all work slightly differently. The anti-CTLA releases the brake on the immune system. So cancers are very clever in evading the immune system from attack. The immune system is trying very hard to locate any cells that look different or look deranged from the cells that they're supposed to be. And the cancers are able to evade it by putting these brakes on the immune system. And so this particular class of drug takes the brake off, which then allows the T cells to activate and expose themselves, or the cancer cell to expose itself to the T cell, resulting in cell death. The anti-PD1 works slightly differently. The immune system is constantly trying to kill cells that don't look normal or don't look like self, and they get exhausted in that process. And so these particular drugs are looking to reactivate those and give those T cells some energy to recognize this non-self and go in and kill the cell and cause cell death. And then the anti-PD-L1 cells is about restoring normal T cell activity. And another way to look at it, if you like to think of things pictorially, is the cartoon in the right-hand corner, which shows that the CTLA drugs and the PD-L1 drugs will actually work on the T cell doing the job of recognizing non-self, whereas the PD-L1 drug works on the tumor cell. So slightly different in their actions. And I've put a link there on the bottom if interested to go and get some more information about the modes of action and how they are working. So this is just a small slide of the various classifications of drugs and the drug names that we are currently using. There are more now, of course. But I think the important thing in this slide is that the column that it's used to treat. We know very successful therapies have been within melanoma, lung and renal cell, but it's really now spreading across the cancers, and you will see these drugs being used more and more in the therapeutic pathways of many additional cancers and many trials going on. So what do nurses need to think about with checkpoint inhibitors? Well, in some ways it's no different than any other anti-cancer therapy, but actually the speciality of immunotherapy is different. And it is important that we distinguish it from chemotherapy for patients in particular. So the first thing to do, of course, is make sure we understand the patient in front of us. So making sure that we get a good baseline history from that individual. Who are they? What's important to them? What's individual to them in terms of their medical history? And do they have any conditions that might impact the fact that we're going to modulate their immune system? Really important to me, and I think very fundamental to any anti-cancer therapy, any cancer therapy that is killing cells and therefore causing some problems, is the way that we coach and educate patients regarding their symptoms and when to opt into healthcare. So many approaches currently are around self-management and advising people that you may develop some diarrhea, you may get a sore mouth, you may have a temperature similar to what the previous speaker was saying. But the important thing is that they know when it's gone beyond self-management and when they need to opt into healthcare to help them with their with whatever it is they're suffering from. So we call this activation, patient activation. So self-management is okay up to a point, but when is it not enough and you're going to need health care? For the nurses in the treatment room, of course, there are administration concerns. Some of these drugs do cause hypersensitivity reactions. Some of the drugs require pre-meds. Some of them require titration. Some of them don't. It's very individual to the drug, so it's important that we understand the background to the drugs that we're trying to give and make sure that we're consistent in that approach with the patients. From a point of view of monitoring adverse events or side effects, surveillance is really important, and it's really, really important in immunotherapy to act early and get some systems in place to be able to recognize when things might not be going quite to plan. And then, of course, if things do escalate and an individual might need some therapy for any particular side effects, then it's important from a nursing point of view that we're coaching patients about what's happening, recognizing perhaps their disappointment about what's going on in terms of they may no longer be able to have their anti-cancer treatment, but they've also got another thing to be managing and coping with in getting whatever the side effect is under control. So if therapy is needed for any adverse events, it's usually in the form of steroids, and if steroids are not working, then some further interventions. But from a nursing point of view, it's really important to understand, for the patient to understand and the medicines management that is required, and any supportive issues that they may have along that particular journey. As I said earlier, anybody having anti-cancer treatment, there are some baseline fundamentals that need to be incorporated into any sort of nursing care management, and that's no different for immunotherapy. So lots of education around what is good behaviours for treatment, perhaps some additional information around protecting the gut in this instance, and also any medicines management issues that should arise, or new therapies. Remembering again, with immunotherapy, often there is a longevity of treatment, so other things occur, other health issues occur, and so it's just important we all understand what else is going on besides this cancer diagnosis that we're involved with. Basic side effect management or adverse event management is the same for any assessment and intervention. So we need to assess the signs and symptoms first of all, and have a little think about what is the problem for that particular patient. We need to determine the cause, other non-inflammatory causes, and as I said, patients are on this therapy for quite some time. So could it be something that is nothing to do with their actual treatment? We will still use the common terminology criteria for adverse events for grading the severity of the symptom or the problem. We would then identify appropriate intervention, and then very importantly, we would do ongoing surveillance, whether that is to the intervention or whether it is to with an aim to get them back on their therapy. So what are the side effects of immunotherapy or checkpoint inhibitors? Basically, because we're asking the immune system to attack the cancer, any organ could be involved in terms of causing problems or causing some adverse events. And we're looking for signs of inflammation. So any condition that has an itis on the end implies inflammation. So we're looking for a pneumonitis in the lungs. We'd be looking for a hepatitis in the liver, a colitis, obviously in the colon, but other things as well, a pancreatitis, a cholecystitis, a hypophysitis in the brain. So any organ can be affected, and any signs of inflammation needs to be taken very seriously and very cautiously. And it's important with immunotherapy that toxicities may be very clear. So some will show themselves in the form of a symptom. So colitis, obviously a patient is going to develop diarrhea. Dermatitis, a patient is going to develop a rash or a skin problem. But others are more subtle. So hepatitis, the things that you may notice are liver enzymes or bilirubins that are starting to elevate or become deranged. The patient may have no symptoms whatsoever. The same with the nephritis, they may get some renal toxicities, but actually the patient would never know. So this is when surveillance becomes really important, and the blood tests that are monitoring these effects become really, really important. And it's very clear that these symptoms can happen at any time during this lengthy treatment or when treatment has finished. So it is important to do the whole gamut of surveillance, drugs, bloods. And what happens with the reason people are developing side effects or adverse events from their immunotherapy is because we've activated the immune system a little bit too much. So we talk about we've turned the heat up on the immune system too much, and it's starting to attack self as well as non-self. So what we need to do is to turn the heating down, turn the immune system down a little bit to get things back under control. And the way that we would do that is to suppress the immune system using steroids initially. So oral prednisolone or IV methylprednisolone. And again, oral prednisolone is often a tapering dose. So nurses really come into education about medicines, about when to stop, about when to reduce doses, and supporting them again, possibly with side effects of steroid therapy. In the early days of using immunotherapy, these would be inpatient approaches, but now very much oral prednisone and indeed IV methylprednisolone is treated as an outpatient in the main. Obviously, if things are not working, we would move on to additional drugs that would help in the treatment pathway, and this may well result in an inpatient admission. But from a nursing point of view, obviously things are not quite right for the person. It may result in them stopping their anti-cancer therapy, which has a psychological input, and all the impact on their family and things. The nursing is really going to come into their own here in supporting the patients and helping them understand what actually is going on. And monitoring response again is clearly very important. So I've got a couple of cases to illustrate. One is, they're very different in terms of their severity. So just to illustrate the points that I've just been showing you. So case one, this is a young man who was very fit and active. He's a gardener and working full time, and he presented because he had shoulder pain and arm pain. He was quite well. He was working as a gardener, as I say, full time, looking after his young family. Nothing particular in his history. His overall performance status was not. But as he was investigated, unfortunately, he developed a T2, a T3 squamous cell carcinoma of his lung. And unfortunately, he was noticed to have a single adrenal gland metastases. So he went on to have, given he was very fit and his performance status was naught, he went on to have chemotherapy, radiotherapy, which we would consider a radical approach. And he had a very good response to that. And once he'd finished, he had the metastases on his adrenal gland removed through a laparoscope. Unfortunately, at the same time, after that was all completed, he had a CT scan and they found that he had a surface liver metastases, which was not suitable for radiation. So he was then, at the time, we had a trial open called Checkmate 171, and he was enrolled to have nivolumab. So he had nivolumab every 2 weeks, and at his 3-year point, his CT scan showed complete stable disease. He was back feeling pretty much back to normal in terms of his work, in terms of his energy, in terms of him carrying on with his normal life. But he was starting to develop these skin changes and nail changes. And these pictures, I hope they project well, but these pictures were similar around his toes, although I don't have any pictures of his toes. And so again, we were thinking about, well, what should we do about this? Because he was clearly bothered by this. They weren't painful. It wasn't any sort of detriment that was other than psychological from his point of view. But he was a gardener as well. So we wanted to make sure that he didn't have any sort of chronic infection or chronic fungus, perhaps that might be clouding our cause that was the immunotherapy. So we looked at the guidance. We're fortunate to have some guidance, some nursing guidance, which is on the left, and then on the right is ESMO guidelines, European Medical Oncology guidance. And we kind of thought that, well, maybe this is grade 1, grade 2. Grade 2 sort of gets you into a 30% of your body being affected. But clearly his concern was really psychological. Every time he was looking down at his hands and they were unsightly, he was reminded of his cancer, even though he was coming for treatment every 2 weeks. So we decided we'd treat them with some steroid cream, and we would continue on with the nivolumab. And remember, he is on a clinical trial at this point as well. We looked at some of the guidance afterwards, and it is immune-related skin reactions are thought to occur early, actually in the treatment pathway. And he was at 3 years when this was noted to us, where he was reporting it to us. Although it would take a little while for it to develop. So for our own interest as well, we decided that perhaps we should ask our dermatologist to have a look at it and see if there was anything that we could understand, or if there's anything more that we could do about it. And this was the report. But the important thing is the bottom sentence, I think, which says, overall, it would appear that this gentleman most likely has a drug-induced psoriatic formic rash. And we had an update talk with the registrar, which included nivolumab, and I do recall that this might be a problem. So, we were learning alongside our experts, so they didn't all have the answers for us. But this is his fingers now at 5 years. which you can see they have, his feet are better, interestingly. But you
please
can see
your lecture, sum up your lecture. Your time is out. Please sum up your
okay, I will finish in 2 seconds. Thank you. This clearly is an ongoing chronic problem for this chap. He still remains on his nivolumab now, and he's getting used to the fact that he's got these. Just as a by this, I've got 2 more slides then. Just as a by the way, this guy was just before his 75th cycle. He was washing the dishes and noticed a sharp pain in his side. He was a little bit short of breath, and he was coming to the hospital the following day. And so he reported this to us. He did walk up a big hill to get to the hospital, and so of course we started to think around pneumonitis, but actually it turned out he'd had a spontaneous pneumothorax, and this was managed very conservatively, and he was able to continue on with his treatment. I will just skip past the next, just go to my final slide then. You're very welcome to the slides. The other one is about a much more serious colitis. But I think the challenges with the immunotherapy, still lots to learn, obviously, still need to engage specialty colleagues, and the issue is now about when to stop treatment. And the principles to leave you with: report early, early identification of the toxicity, early management of toxicities, and all of this requires good nursing care. I thank you for your time. I'm sorry for going over.
Thank you, Dr. Ellen, for a nice lecture given by you, and the nurses and the nurses' role and the responsibility in the field of immunotherapy. And we hope that in our country too, we should train our nurses like this, like in the Western countries, so they can bear more responsibility. And our nurses' responsibility, if we share with them, then it will be better, because patient's load is too much. If they know all these things nicely and understand the things, then we can do more better work. Hopefully, we will also, Dr. Lalit is taking care of all these things in our state. Hopefully, we will train our nurses like this and do the good. Thank you very much. And now I will invite.
Thank you, Dr. Bhatti sir. May I request? Thank you for your kind words. May I request Dr. Tanwar sir for inviting the next our own girl Kavita Sharma, please. Dr. Tanwar sir, please.
Good evening. I invite Mrs. Kavita Sharma. She is assistant and nursing superintendent at Mahatma Gandhi Hospital and Medical College, Jaipur.
Good evening, all respective person. Especially thanks to Dr. Hemant sir and Lalit Mohan sir for giving me opportunity on behalf of this. My topic is the role of oncology nursing in palliative care and end of life care. Next. Definition as a WHO, as per definition, improve the quality of life patient with the life-threatening illness and suffering from many means early identification, impeccable assessment, treatment, problem, physical and psychological future. Next, sir. Next slide, sir.
Ma'am, actually, you are sharing your screen.
Okay.
Yeah.
Okay, ma'am. Okay, thank you. The palliative care is help to manage suffering of patient and provide care for at the end of lives and their families. This data show that the number of patients who need palliative care now before the showing 20 years and coming 20 years. In coming future, more and more patients will be need palliative care support. And this data is annual death in globally it can be estimated that approximately 60% of the dying patient need palliative care. Palliative care can be divided into three parts: palliative care, end-of-life care, and terminal care. In palliative care, life-limiting illness, symptomatic management, psychological support, and end-of-life care is the condition of non-curative, home support, and spiritual healthcare and physical support. Terminal case in symptomatic management, spiritual care, and days of hours of life. In palliative care, including this is a palliative care is not for cancer. It is useful regards to disease other than cancer, just like CKD and HIV, chronic heart disease, progressive neurological disorders, etc. Involving models show the purpose is model palliative care intent to this maximum comfort provide the patient and family person. बिकॉज जब पेशेंट को मालूम पड़ता है कि उसे कैंसर है, उसको एक्टिव ट्रीटमेंट की जरूरत है और उसका पैलिएटिव केयर में डेथ हो जाती है, लेकिन क्योर एंड प्रोलॉन्ग के अंदर पेशेंट में ये दिक्कत आती है कि उसके जो फैमिली मेंबर्स हैं वो बहुत ज्यादा हताश हो जाते हैं, पेशेंट खुद हताश हो जाता है, पेशेंट की डेथ के बाद उसके फैमिली मेंबर्स को स्पिरिचुअल सपोर्ट करना पड़ता है. The aim of palliative care. The aim is to relate to patient's symptoms, improve quality of living, threatening illness, physical, psychological, social, and spiritual support, and balance of mind. Principle of the palliative care is we respect to like and dislike, integrate psychological, spiritual, social aspect. We should be patient-centered rather than disease-focused. And we want to life today is we want to say ki add the life today and not day to life. We need to support entire family, the help them get good health care. Palliative care program included, many programs are included in our India and our out of India. Because the purpose for manage life and cope of the loss and grief patient and family members. Palliative care, how to deliver, patient को हम अच्छी केयर दे सकते हैं, उसके साथ फैमिली सपोर्ट के उनके फैमिली वालों को एजुकेशन कर सकते हैं, कोप ऑफ दिस लॉस एंड ग्रीफ ड्यूरिंग इलनेस के बारे में उनको बता सकते हैं. फिजिकली स्टेजेस ऑफ लाइफ है, इट मे बी प्रेडिक्टेबल और नॉन अनप्रेडिक्टेबल भी हो सकती है. इट मीन्स कि पेशेंट को हमें कैसे उसको एंटायर उसको समझाना है कि ये क्योरेबल ट्रीटमेंट नहीं है, आपको आगे तक जाना है, लाइफ का एंड नहीं है, एंड है तो पीसफुल एंड होना चाहिए. फिलोसफी में हम ये कह सकते हैं पेशेंट को कि अवर इन्वॉल्व टू प्रोवाइड बेस्ट होप, फीलिंग्स, कॉन्फिडेंस, डिग्निटी और अप्रोच कर सकते हैं उसको, लाइफ लिमिटिंग इलनेस को उनको समझा सकते हैं, साइकोलॉजिकल सपोर्ट दे सकते हैं उनको, स्पिरिचुअल के अंदर हम हेल्प कर सकते हैं, कैसे एक नर्सेस बेटर टू बेटर कर सकती है पेशेंट के लिए. एंड ऑफ लाइफ केयर में व्हाट इज एंड ऑफ लाइफ केयर, फाइनल स्टेज है. Let me know now let's see what is the end of life care. It is final stage of life. It may be predictable or this may be not predictable. We provide it's maybe last month, last moments, last few months, few days or few weeks and few months. We provide physical and again psychological, spiritual care of the patient and family members. Our goal in nursing prevent for suffering of the patient whom the cancer. जो पेशेंट कैंसर से सफर कर रहे हैं उनको उनके लिए प्रिवेंशन करना, उनके प्रोवाइड कंफर्ट, उनको सपोर्ट करना, मेंटेन उनकी डिग्निटी को, उनकी बातों को सुनना, उनके लिए विशेष करना, उनको इस तरह से मोटिवेट करना कि वो जो उनका टाइम पीरियड है वो बहुत पीसफुली निकालें, फियरलेस निकालें, और बिना किसी डर के वो अपने ट्रीटमेंट के साथ सपोर्ट करें, फैमिली मेंबर्स को उनको सपोर्ट करने को मिले, और उनकी डिजायर को ध्यान में रखते हुए इम्प्रूवमेंट उनकी लाइफ और पेशेंट फैमिली मेंबर्स को हम इनकरेज करें कि आपको ये सब बहुत ही शांति और धैर्य के साथ इसको एडमिट करना है। मिथ्स हैं पैलिएटिव केयर के बारे में, बहुत सारे मिथ्स हैं, अनकाउंटेबल मिथ्स हैं, लेकिन इसके अंदर अपन कह सकते हैं कि पैलिएटिव केयर अवेलेबिलिटी नहीं है हमारे पास इंडिया में बहुत सी जगह पर, अच्छे हॉस्पिटल्स नहीं मिल पाते पेशेंटों को, उनको पैलिएटिव के एक्सपर्ट नहीं मिल पाते जो उन्हें राय दे सके, पैलिएटिव हेल्थ वर्कर अच्छे नहीं मिल पाते जिसकी वजह से वो पेशेंट ट्रीटमेंट के बिना महरूम रह जाते हैं, अप्रोचेबल नहीं होते पेशेंट्स कि वहां तक पहुंच सकें या उनको प्रॉपर ट्रीटमेंट मिल सके। इसके लिए हमें मतलब ये मिथ्स हैं जिनको हमें हटाना है, लोगों को समझाना है कि नहीं ऐसा नहीं है, आप वहां तक पहुंच सकते हैं, ट्रीटमेंट आपके पास पहुंच सकता है, नर्सेज आपको मिल सकती हैं, अगर वो पेशेंट की केयर में खुद नहीं आ सकता तो हम घर तक जा सकते हैं पेशेंट के नर्सेज केयर के लिए। एंड एज अ नर्स डायग्नोसिस अगर पेशेंट को हम करते हैं, पेशेंट हमें कंप्लेन करता है कि मुझे पेन है, तो हम उसे कैसे असिस्ट करेंगे, एनाल्जेसिक दे सकते हैं, उसको एंजाइटी रिलीफ कर सकते हैं। अगर वो कंप्लेन कर रहा है कि मुझे आइसोलेशन चाहिए तो पेशेंट को हम समझा सकते हैं कि आपको सोना चाहिए, अच्छी तरह से पीसफुल रहना चाहिए। इम्पेयर्ड कंफर्ट के अंदर हम पेशेंट्स को कह सकते हैं कि मतलब वो अपना पीसफुल पोजीशन चेंज करके सो जाए, हेड एलिवेट कर ले। उसके बाद भी कई बार पेशेंट इन सब चीजों के बाद भी पेशेंट सोशल विड्रॉल करते हैं, वो चाहते हैं कि हमें मतलब नहीं, किसी से नहीं बात करनी, किसी के साथ नहीं रहना, तो उनको अपनी बात से समझाना, उनसे सॉफ्ट मीठी बात करके उनको जेंटल टच दे के समझाना है कि नहीं ये ऐसा नहीं है, अगर आप थोड़ा सा कोऑपरेट करेंगे तो और भी ज्यादा इम्प्रूवमेंट आपको देखने को मिलेंगे। सेम थिंग इज द डिजायर, उनके पेशेंट्स की क्या बॉडी कैसी है, इलनेस है, वो कैसे अच्छे हो सकते हैं, पेशेंट और पेशेंट की फैमिली, उनको सबको मिलके समझाना होता है कि आप किस तरह से अपने पेशेंट को बेटर केयर दे सकते हैं, कैसे उनकी डेली रूटीन लाइफ को आप बहुत अच्छा कर सकते हैं, पीसफुल माइंड कर सकते हैं, भगवान का ध्यान, योगा वगैरह आदि चीज बता के उनको मतलब मेंटली उनको प्रिपेयर करना है इस चीज के लिए कि आपको ये सब करते हैं तो आपको इन सब का बेनिफिट्स मिलेगा। दिस पिक्चर इज शो कि मतलब इसमें पेशेंट को जैसे उसे फाइंड आउट हुआ कि उसे बहुत कैंसर हो गया है तो वो बहुत गुस्सा होता है, नहीं नहीं ये मेरे साथ नहीं हो सकता, मेरे साथ भगवान ने ऐसा क्यों किया, मैंने किसी का क्या बिगाड़ा, वो बहुत नाराज होता है, मतलब डिनाई करता है, इनकार करता है कि मेरे को ऐसा नहीं हो सकता, और वो अपने परिवार वालों पे, अपने साथ वालों पे गुस्सा करने चालू कर देता है। लेकिन धीरे धीरे उसके मन को समझ आती है, जब वो ट्रीटमेंट में जाता है, लोग डॉक्टर से मिलता है, बात करता है, नर्सेस के साथ रहता है, वहाँ पे हॉस्पिटल में एडमिट होता है, तो वो इस चीज को स्वीकार करता है, फिर वो अपने आप से सौदेबाजी करता है, क्या मैं ट्रीटमेंट करवाऊं, क्या मेरे साथ ऐसा होगा, क्या मैं जी जाऊंगा, क्या मैं मर जाऊंगा, इस तरह की बातें उसके दिमाग में चलती रहती है, और वो इसके चलते वो डिप्रेशन में चला जाता है। लास्ट में फिर पेशेंट इस चीज को एक्सेप्ट कर लेता है कि हाँ मुझे ये बीमारी है और मुझे अपना इलाज कराना है और अपनी लाइफ को बेटर करना है, पीसफुल डेथ को पाना है, ना कि मुझे तड़पते हुए मरना है। साइकोलॉजिकल असेसमेंट एज अ नर्स हमको उसका जो बात करके देखना है कि वो किस फेज में है, वेदर देन सोशल विड्रॉल है में है, पेशेंट अकेला फील करता है, उसको फियर है, एंजाइटी है, ग्रीविंग एंड सैरो है, या उसकी भगवान से नाराजगी या अपनों से नाराजगी है, या वो बिल्कुल नहीं जीना चाहता। इन सब चीजों को हमें पेशेंट से बात करके आइडेंटिफाई करना पड़ेगा, उसके कंफ्यूजन्स को मिटाना पड़ेगा, उसके दर्द को कम करना पड़ेगा, बेटर ट्रीटमेंट क्या दे सकते हैं उसके सोने के लिए, उससे अच्छा हम क्या कर सकते हैं, ये सब चीजें हमें पेशेंट से बात करने के बाद उसको सब चीजें प्रोवाइड कराएंगे तो मे बी पेशेंट का इंटरेस्ट अपनी लाइफ में बढ़ता है और वो उस चीज से कंफर्ट जोन से पेन के कैंसर के जो टेंशन है और वो पैलिएटिव केयर को अपने आप एडेप्ट कर लेता है। As a nurse's responsibility, there is a multiple responsibility our nurses gain. because she need create to a bond, again trust, and she's sensitive to them. We get understand to the family wishes and the life care, learning under family wishes, यूजिंग कम्युनिकेशन, उनसे बात करने का, इम्प्लीमेंट करने का तरीका, उनको समझाने का तरीका कि लाइफ को हम कैसे इजी और स्मूथ कर सकते हैं, उनको हेल्प कर सकते हैं, इंटीग्रेट सोर्सेज उनको बता सकते हैं हम अपने, और उनकी थॉट्स को हम थोड़ा चेंज कर सकते हैं बात करके कि ये ऐसे अगर हम करते हैं तो हमारे को बेटर थिंग रहेगा। और दूसरा, पेशेंट को फिजिकली मेंटली जो उसकी कंडीशन है उसको ओपन, उसके क्वेश्चन से उनसे बात करके उनके क्वेश्चंस को सॉल्व करना, उनकी नॉलेज को बताना, नॉलेज के बारे में उनको बताना कि हाँ आप इस चीज़ को जान सकते हैं, अपने डिसीजंस ले सकते हैं, और थेरापेटिक रिलेशनशिप बता सकते हैं अपन, अवेलेबिलिटी क्लाइंट्स ऑफ चूज नॉट टू बी ओपन, इस कन्वे कर सकते हैं हम इसको कि आप किस तरह से अपने पैलिएटिव केयर में आते हैं तो आपके पेशेंट्स को कितने बेनिफिट्स हो सकते हैं, कितनी अच्छी केयर मिल सकती है टिल डेथ तक। बैरियर इन पैलिएटिव केयर, मैनी बैरियर्स इन पैलिएटिव केयर इन इंडिया। एक तो इलिटरेसी है, यहाँ पर इग्नोरेंस है, वहाँ पे लोग बाग सुनना भी नहीं चाहते इस बारे में कि हमें कैंसर हो गया है तो उसका हम इलाज करा सकते हैं। कॉपरेट नहीं करते स्टेजेस ऑफ कैंसर के बारे में जानने के बाद। गाँव में तो इतना है कि अगर आपको कोई तकलीफ है तो उसको छुपा लिया जाता है, बताते नहीं है, जब वो बिल्कुल एडवांस स्टेज में आता है तब जाके वो आते हैं, तो यहाँ पे भी हमको बैरियर होता है, हम पेशेंट केयर नहीं कर सकते। फाइनेंशियली प्रॉब्लम है इंडिया में बहुत ज़्यादा, लोग बाग पैसों के अभाव के चक्कर में ट्रीटमेंट नहीं पाते, कई लोग पैसा लगा के भी ट्रीटमेंट पूरा नहीं ले पाते क्योंकि उनके पास सोर्सेज अच्छे नहीं हैं, ट्रेवल्स नहीं कर पाते, दूर दूर गाँवों में रहते हैं जो यहाँ तक पहुँच नहीं पाते, शहरों तक नहीं पहुँच पाते, अच्छे डॉक्टर से नहीं मिल पाते, और कुछ इश्यूज आते हैं नार्कोटिक ड्रग्स नहीं मिल पाते उनको, जिसके बारे में ड्रग का मालूमात ही नहीं कि ऐसा भी कोई दर्द है कि जिससे हम अपनी पेन रिलीफ लाइफ को जी सकते हैं। और हेल्थ वर्क की इनएडुकेट ट्रेनिंग है, उन हेल्थ वर्करों को प्रॉपर ट्रेनिंग नहीं मिलती, नर्सेज को अपॉर्चुनिटी नहीं मिलती। मैंने मेरे इन कैरियर में मैंने ये देखा है कि नर्सेज भी इस ऑन्कोलॉजी में आना नहीं चाहती, उनको एक डर है, फियर है, एंजाइटी कि अगर हम कैंसर फील्ड में जाएंगे तो हमें भी कैंसर हो जाएगा, इनफर्टिलिटी हो जाएगी, हमारे घर वाले हमें इनकार करते हैं। मेरे खुद के हॉस्पिटल में मेरे को कई स्टाफ ऐसा कहता है कि हम कैंसर यूनिट में काम नहीं करना चाहते क्योंकि अदर यूनिट ज़्यादा ईजी है काम करने के लिए, और इन्वेस्टिगेशंस भी इसमें बहुत हायर होते हैं। इन चक्करों में लोग बहुत डर जाते हैं कि साहब बहुत महंगा इलाज हम कैसे कराएंगे, इससे अच्छा तो मर जाना बेटर है। ये सब चीज़ें हमारे इस पैलिएटिव केयर के लिए बहुत ज़्यादा बैरियर हैं। एंड साइकोलॉजिकल इंटरपर्सनल स्पिरिचुअल एडिशनल रिस्पॉन्सिबिलिटी है नर्सेज नॉलेज टू स्किन मैनेज और अदर डिस्कसिंग सिम्टम्स ऑफ द पेशेंट कर पाते हैं। इसके अंदर सबसे ज़्यादा प्रॉब्लम ये आती है कि नर्सेज को नॉलेज जितनी अच्छी होगी उतना ज़्यादा वो पेशेंट्स की केयर बेटर कर सकेंगे, अच्छे हेल्थ वर्कर अच्छा काम कर सकेंगे, पेशेंट केयर अच्छी दे सकेंगे। एडवांस केयर प्लानिंग काउंसलिंग के अंदर एडवांस ट्रीटमेंट के बारे में हम उनको बता सकते हैं, एडवांस पर्सन्स बेनिफिट्स बता सकते हैं, वैल्यूज़ बता सकते हैं उनको पेशेंट्स के बारे में, एंड जो पेशेंट्स कर नहीं सकते उसको हम प्रोवाइड करा सकते हैं, उनको हेल्थ केयर प्रोवाइडर्स की तरह से उनको सपोर्ट कर सकते हैं अपन। Nursing care including are not disease management, recognize the patient. Sir, I can see my full screen. I can't able to full screen mine.
Ma'am, your slides are visible. Just click on the slides.
No, ma'am, back there.
Yes, ma'am, your slides are moving.
एडवांस केयर एंड प्लानिंग के अंदर काउंसलिंग कर सकते हैं हम पेशेंट को कि बेटर से बेटर हम ट्रीटमेंट दे सकते हैं। इसके अंदर एडवांस पर्सन एबल टू हिमसेल्फ कि भाई कितना हमें बेटर मिल सकता है, तो पेशेंट ट्रीटमेंट के बारे में पैलिएटिव लाइफ केयर के बारे के अंदर हम उनको अच्छे से बता सकते हैं। फैमिली मेंबर्स को हम नर्सिंग केयर के बाद में इंक्लूडेड नॉट ओनली डिजीज मैनेजमेंट बट आल्सो अटेंशन द फिजिकल कंफर्ट recognize the patient well-being, also comprehensive physical, psychological. Nurses should be have knowledge to manage pain and distressing symptoms of the patients. In our hospital, I am working the Mahatma Gandhi Hospital. It's a 1400 bed hospital college, and palliative care is a part of oncology team. And per month, our have load is 250 to 200 to 50 patients. एंड पैलेटिव केयर इज नीड 24 आवर्स हमारे हॉस्पिटल में है. इसमें कभी भी 24 घंटे में ऐसा नहीं कि पेशेंट अगर कभी आधी रात को भी आया तो हम उसको पैलेटिव केयर का ट्रीटमेंट नहीं दे सकते, ऐसा नहीं है. काउंसलिंग होती है, बाकायदा पेन मैनेजमेंट किया जाता है. और इसमें ओपीडीज हमारे पास है जो 9 to 5 खुलती हैं. उसके बाद डॉक्टर्स रहते हैं जो 24 आवर्स में कभी पेशेंट आए उसको पैलेटिव केयर का ट्रीटमेंट स्टार्ट हो जाता है. और एक टेली कंसल्टेशन है, जो अगर पेशेंट नहीं आ सकते जो लोग, उनको घर पे टेली मेडिसिन के द्वारा ट्रीटमेंट बताया जाता है. कोलोरिस करके सर्विसेज है हमारे हॉस्पिटल में, जो हॉस्पिटल अपनी तरफ से पूरा प्रोवाइड करता है हर चीज उनको. मेडिकल सर्विसेज ले लीजिए आप, उनको मशीनरी इक्विपमेंट्स ले लीजिए, मेडिसिन ले लीजिए, नर्सिंग स्टाफ ले लीजिए, एवरीथिंग विल बी प्रोवाइडेड अवर हॉस्पिटल एंड पैलेटिव केयर. दिस आपको स्क्रीन पे दिख रहा होगा, ये पॉलिटिक्स का मेडिकेयर का. ये हॉस्पिटल की तरफ से इतनी ही सेवाएं पेशेंट्स को दी जाती है ताकि पेशेंट को, जो पेशेंट नहीं आ सकते, जिन पेशेंट जो एबल नहीं आना चाहते हैं, वो चाहते हैं हमारा घर में ट्रीटमेंट हो, तो उनको हम पॉलिटिक्स के माध्यम से बेटर केयर देते हैं. नर्सिंग स्टाफ को देते हैं, वहाँ पे उनको सब चीज उपकरण वहाँ उपलब्ध कराया जाता है. इवन एम्बुलेंस भी प्रोवाइड करी जाती है अगर वो कुछ टाइम के लिए अगर आप अपने आप को आके दिखाना चाहें तो. And at the end, I would like to say that palliative care is very important component to cancer. It can be delivered either the hospital, home, or community. And nurses should be promote palliative care for the patient who not be cured. And barrier can be decreased when advanced disease our patient can give, and we can give guide. Physician to provide for palliative care. Caregiving says palliative care is most important for our patients, or mostly cancer patients. Thank you for attention.
Thank you very much, Kavita, for your nice presentation. And your job is very difficult to the difficult patients and their relatives. I congratulate you for excellent presentation. Thank you very much.
Thank you, sir.
So, Kavita, I will add something and I will comment on this. The palliative care is the most important in our patients because most of our patients ultimately go for a palliative care.
Right,
And unfortunately, this is not very much developed in country in India. Earlier,
Yes.
we were thinking that the joint family system was the good. I belongs to a small village. When once anyone gets sick, then everybody used to help them out. Now that the things are changing very fastly, nuclear families, so it's very difficult. So dedicated nurses are the most important pillar of the palliative care, and they can understand things very fastly. Dedicated in services done by the heart. And
Right, sir.
I can give one example. We had two nurses from the Jeevdaya Foundation at our medical oncology department, and both were the male nurses. And I have selected on the ground that the people had a serving attitude. The both boys has been trained in a nice way in the best of the centers of the country, and they worked with me 5 years, and it was so dedicated and impressive. So I can see, I can tell them this is one of the best example in the country. And fortunately, because of their services, they got the 30% extra marks in the government job, and they got a job in a government, and still they are doing good job. And another thing, they have trained in all things. So now even as a nurse, if they practice for to earn money, they can also earn money. And if you want, they want to serve the people, they can serve the things. So I think this is the important thing of the oncology.
Thank you so much, Professor
you, sir.
Bhatti sir, Dr. R.K. Tamar sir, and my colleague Kavita Sharma for taking excellent talk about the palliative care. So, may I request Dr. Hemant Malhotra sir to introduce our third pillar, Dr. Gopala Kawali. He is the main man behind this all inception of the idea.
Thank you, Lalit. And I think I would like to second what Dr. Girdhar Singh Bhati is saying. Like Girdhar and me, we've been in oncology for 30 years, and like it is also my firm conviction that the most important thing in cancer treatment is palliative care. And palliative care starts with the diagnosis of a patient, even in first stage. And thank you very much, Kavita, for a wonderful talk, and we're very proud to have you on our team. I'd like to welcome Dr. Gopala to the webinar. He's at the moment in Texas, USA. It must be very early in the morning for him. So, Dr. Gopala, thank you for coming on board. And with your permission, we'll continue with the program. We're a few minutes late, but that usually happens when you have a program over several hours and several talks. So, would you like to say something, or should we continue, Dr. Gopala?
So what is the next? I thought all the talks are over, right? Just my remarks and the.
We have an extremely important part, the panel discussion. Which,
okay, then I can actually say a few words and then move on to my job.
Sure. Then maybe after the panel discussion, Dr. Gopala can give his concluding remarks. So Lalit, back to you.
Yes, sir. Thank you so much, and thank you, Dr. Gopala, for joining us this early morning. So may I request Sindhu Nair? She is Assistant Nursing Superintendent.
Lalitji, how long is the panel discussion? I mean,
it's for half an hour, sir. 30
okay,
minutes.
Then can I say a few words and then go?
We will love that if you can be with us for next 30 minutes or so.
I have a deliverable.
Okay. Right, sir. Right, sir. Please go ahead, sir.
Yeah. Just I don't take much time. I just wanted to thank all the speakers. By the way, it's me. The photo you are seeing in the brochure also is me. That's a long time back. So what age does to all of us. Thank you all the speakers. Excellent talks. We all know the nurses are a very critical part of their care, especially in the oncology care. I know firsthand when my father was in the All Indian Medical Sciences being treated for leukemia. So I have firsthand appreciation for all the nurses. So this is my way of, thanking back all the nurses by being part of the commemoration of World Nursing Day today, Nursing Month. Just Dr. Malhotra will be probably saying a few words about our foundation, but we have been doing several activities under the Carcinogenesis Foundation, and then this Dr. Malhotra is the president of the India chapter. Thank you, sir, for stepping up and taking care of the India chapter for past 1 year. We have many more events coming up. We are celebrating No Tobacco Day on 31st of May. We will communicate more details to you. Again, with this, Dr. Lalit, thank you very much for putting this wonderful program together and organizing it. Thanks, everyone.
Thank you, sir. Thank you so much for your kind words. With this, may I request Sindhu Nair to start the panel discussion.
Hello, can you hear me?
Yes, Sindhu, you are audible.
A warm good evening to all of you. I hope all my panelists have got connected. So I take the pleasure of introducing my panelists before starting the panel discussion. So I introduce my panelists. The first to go is Ms. Renu Meena. She's from Bikaner and she works with the oncology department as a senior nursing faculty. She works with the Sardar Patel Medical College in Bikaner with over 20 years of experience. So welcome Renu to the panel discussion. Hi Renu. Renu, you need to put your mic on.
Hanji ma'am. Good evening all respected panelists.
The next person is Kavita Sharma. She's from Jaipur. We just heard her, a beautiful talk, Kavita. Thank you very much.
Thank you, ma'am.
The next, she is the assistant nursing superintendent working with, at the moment, she works with Mahatma Gandhi Hospital and Medical College, Sitapura, Jaipur. And she has over 25 years of experience, and she has worked in various hospitals in various capacities, which includes palliative care, and also has an experience as a teaching faculty also. Welcome, Kavita, for the panel discussion.
Hello, ma'am.
Hi.
Hello to panel.
Thank you. Along with us, we have Surya Sukumaran from Rajiv Gandhi Cancer Hospital. A warm good evening to you, Surya. Hi, Surya. Surya, we can't hear you. She is a nurse educator. Good evening, Surya. She is a nurse educator who's working with Rajiv Gandhi Hospital. She's working with Rajiv Gandhi Hospital and she has also an experience of working with Fortis Hospital. She is a nurse educator with multiple initiatives taken over there. She has a vast experience of conducting a lot of conferences and continuing nursing education. We have along with us Ms. Sri Lekha Rajesh, who is the Chief Nursing Officer of RCC Trivandrum, the Regional Cancer Center, Trivandrum. Welcome, Sri Lekha.
Good evening, ma'am.
Hi. She has got more than 25 years of experience working as a nursing faculty over there. She's also the recipient of the President's Award. Welcome, Sri Lekha, to the panel discussion.
Thank you, ma'am.
We go over to Colonel Madhumita. She is the Chief Nursing Director of Rajiv Gandhi Cancer Institute and Research Center. Welcome, Madam Madhumita.
Hi, good evening, everyone.
Hi. With over 25 years of experience in various faculty positions in various hospitals, at the moment she's associated with Rajiv Gandhi Hospital. Welcome to each and everyone. I'm Sindhu Nair, Deputy Nursing Superintendent, associated with Tata Memorial Hospital for the last 18 years. I will be the moderator for this session. Well, going over to the session. Now, today's topic is nurses' role and scope of practice in the care of cancer patients. Well, successful cancer care requires a team approach, and knowledgeable oncology nurses play a crucial role in functioning of the team. The goal of reducing cancer incidences. The goal of reducing cancer incidences and improving survival for providing better palliative care cannot be met without the effort of these nurses. Well-prepared oncology nurse is the key to having a good oncology setup. अब मैं रेनू को पूछना चाहती हूँ कि आप इतने साल से ऑन्कोलॉजी सेटअप में काम करते हो, तो मैं ये पूछना चाहती हूँ कि आपने क्या देखा है कि क्या इस लास्ट 20 सालों में या 15 सालों में क्या-क्या डिफरेंस हुआ है क्लिनिकल सेटिंग में?
Sorry for the interruption, ma'am. Do you have the lecture slides?
No, we don't have the lecture slide. It is just a panel discussion where all will be speaking extempo.
Okay, ma'am. Thank you.
So, मैं रेनू को पूछना चाहती हूँ कि आपने इस लास्ट थोड़े सालों में क्या डिफरेंस देखा है अपने सेटअप में? पहले आप जब नॉविस नर्स होके आई थी, ऑन्कोलॉजी सेटअप कैसा था, और इतने सालों के एक्सपीरियंस में आपने क्या डेवलपमेंट देखा है ऑन्कोलॉजी सेटअप में?
हाय, गुड इवनिंग मैम.
गुड इवनिंग.
रेणु मीना, मैं बीकानेर सरदार पटेल मेडिकल कॉलेज कैंसर हॉस्पिटल ऑन्कोलॉजी डिपार्टमेंट से. फर्स्ट ऑफ ऑल मैम, मैं 6 मंथ से ऑन्कोलॉजी डिपार्टमेंट में काम कर रही हूँ. अभी तक मैंने जितना देखा है, जितना मैंने जाना है ऑन्कोलॉजी डिपार्टमेंट के, उस हिसाब से बताती हूँ. मेरा टॉपिक्स आज है रोल एंड स्कोप. एक्चुअली मैडम, पहले जो कुछ सालों से पहले जो भी नर्सिंग कैंसर के लोग जो अवेयरनेस थी बहुत कम थी. आज अवेयरनेस है, बट बहुत ही रूरल गांव में बिल्कुल भी अवेयरनेस नहीं. हमारे पास पेशेंट्स आते हैं बीकानेर के आसपास के बहुत बैकवर्ड एरिया के, बट हॉस्पिटल में आने के बाद हमारा यही प्रयास होता है, हमारी यही रिस्पॉन्सिबिलिटी होती है. फर्स्ट ऑफ पेशेंट्स का असेसमेंट करते हैं, पेशेंट्स के एजुकेशन है, कोऑर्डिनेशन ऑफ केयर है, डायरेक्ट पेशेंट्स केयर है या सिम्टम्स मैनेजमेंट है, सपोर्टिव केयर है, ये हम उनको बताते हैं। उनको इस बात के लिए अवेयर कराते हैं कैंसर की बहुत बड़ी बीमारी नहीं है, और बहुत से लोग आगे बढ़कर अपने पेशेंट्स का अच्छे से ट्रीटमेंट करवाते हैं, अच्छा रिजल्ट, अच्छा ट्रीटमेंट ले रहे हैं। हमारी रिस्पॉन्सिबिलिटी क्या है, हम पेशेंट्स को असेसमेंट करें, फिजिकली साइकोलॉजी सपोर्ट, उनका इमोशनल स्टेटस है, क्या पास्ट हेल्थ हिस्ट्री है, पेशेंट का जो
Hello.
Ma'am, Miss Renu has just logged out.
Okay, let me move on to the next panelist. Maybe accidentally she must have logged out. Maybe she will log in once again. Okay, now as Renu was telling that in a village or in a background, it's very difficult to reach out to the nurses because of the setup. So may I ask Kavita that in which way, how can we empower those nurses to reach out? How can we reach out to the nurses over there? How can we empower them in a better decision making? Because obviously it is not as easy as in an urban setting to reach out to the nurses in a rural setting.
Yes, ma'am. मैम जो आपने अभी रेनू से क्वेश्चन किया था कि मतलब कैसा आपका एक्सपीरियंस रहा, जो मेरा एक्सपीरियंस रहा है वो इन सालों में कि पहले के टाइम पे कैंसर में इतनी अवेयरनेस नहीं थी, लोग बाग इतना जानते नहीं थे। धीरे धीरे लोग बाग जाने लगे तो फैसिलिटीज कम होती गई, लोग वहां तक पहुंच नहीं पा रहे थे। अब लोग पहुंच पाते हैं तो ट्रीटमेंट नहीं कराते हैं, ट्रीटमेंट कराने में उनको बहुत ज्यादा हैवी लगता है कि इतना महंगी दवाई है, इतना लंबा ट्रीटमेंट चलेगा, थक जाते हैं लोग। इवन ये कंडीशन आती है कि ना लॉन्ग ट्रीटमेंट होने की वजह से फैमिली मेंबर्स भी है ना परेशान हो जाते हैं। बट पैलेटिव केयर के माध्यम से अगर हम पेशेंट्स को केयर देते हैं तो कहीं ना कहीं मुझे ये फील होता है एज अ नर्स कि पेशेंट को हम बेटर केयर दे सकते हैं उसके एंड ऑफ द लाइफ टाइम में। क्योंकि मैं डे टू डे कई बार पेशेंट्स को देखती हूँ कि मतलब पेशेंट्स का फोर्थ स्टेज में डायग्नोसिस है, यंग पेशेंट्स हैं जिनको मतलब 32 ईयर्स 22 ईयर्स है, उनका डायग्नोसिस ही फोर्थ स्टेज में हुआ है, उनका कोई ट्रीटमेंट नहीं हो सकता, ना उनकी सर्जरी हो सकती है, ना उनको रेडियोथेरेपी दी जा सकती है, ना उनको कीमोथेरेपी दी जा सकती है। तो लास्ट में उनके पास बचता है सिर्फ पैलेटिव केयर, और पैलेटिव केयर के माध्यम से हम उनको ट्रीटमेंट देते हैं, टैबलेट्स देते हैं, अपन धीरे धीरे उनका जो पेन की इंटेंसिटी वो इतनी ज्यादा बढ़ जाती है कि अपन को लास्ट मॉर्फिन पे आना पड़ता है, और मॉर्फिन देने के बाद वो पेशेंट एक तरह से अचेत ही हो जाता है। तो इसको हम कह सकते हैं कि पिन ड्रॉप साइलेंट डेथ हो गई है, पेशेंट को हमने रिलीफ मतलब पेनलेस डेथ दे दी। और एम्पावर में अगर हम नर्सेस के पास फैसिलिटी नहीं है, नर्सेस आना नहीं चाहती हैं, इस फील्ड में ही नहीं आना चाहते कि हम कैंसर में जाना ही नहीं चाहते। जैसा कि मैंने मेरी प्रेजेंटेशन में कहा कि मैंने अपने डिपार्टमेंट में लोगों को भागते हुए देखा है, नर्सेस को, कि नहीं नहीं हमें ऑन्को में काम नहीं करना, ऑन्को से हमारी लाइफ खराब हो जाएगी, जो पेशेंट्स को कीमोथेरेपी के लॉस होते हैं वो हमें होंगे, जो रेडियोथेरेपी से लॉस होते हैं वो हमें होंगे। मैंने कहा अगर आप अपना डेडिकेशन दोगे, स्पेशलिटी दोगे, तो आपको आगे बहुत ज्यादा इसके अंदर एडवांस है, बहुत अपॉर्चुनिटीज है इसके अंदर, और बहुत ज्यादा इसके अंदर आपको बेनिफिट्स मिलेंगे लाइफ में, कि आपको कई लोगों से कई बीमारियां ऐसी कार्डियक है, न्यूरो है, जिसमें पेशेंट आता है और चला जाता है, उससे कोई इंटरेक्शन नहीं रहता। गायनी के पेशेंट आए, बच्चा हुआ, चले गए। लेकिन कैंसर का पेशेंट डे 1 से, जब से उसकी फाइल बनती है तब से वो हमारे अटैच में रहता है और टिल डेथ तक रहता है। तो उसकी आदतों के बारे में
तो कविता मैं ये पूछना चाहती हूँ कि आपने बताया कि आपने बताया कि काफी सारे नर्सेस उतने स्ट्रांग नहीं होते हैं, उन लोग, आपने एक सेंटेंस यूज किया कि वो भाग जाते हैं। तो मैं ये पूछना चाहती हूँ कि हम हमारे नर्सेस को स्ट्रांग कैसे करें ताकि वो डट के उनका सामना करें।
मैम उनको प्रॉपर एजुकेशन दी जाए, जो एज ए ट्रेनिंग टाइम में वो आते हैं, उनको ट्रेनिंग टाइम के अंदर बेटर एजुकेशन दी जाए, उन्हें सिखाया जाए कि ये चीज अपन करते हैं नर्सेज को, उनको इस तरह से मेंटली ट्रेन किया जाए ताकि उनका मानस है वो क्लियर रहे कि हमें पेशेंट की केयर करनी, फोकस उस पर रहे उनका, ना कि रेदर उनको बेनिफिट्स दिए जाए, फाइनेंशियली बेनिफिट्स दिए जाए, उनको टाइमिंग दी जाए, उनके टाइमिंग शॉर्ट, उनको अलाउंसेस दिए जाए ताकि उनका एक इंटरेस्ट भी बने और दूसरा उनका पेशेंट्स के साथ अटैचमेंट अच्छा हो तो बेटर केयर कर सकें.
Very true. Thank you very much, Kavita. Now, going over and taking over from what Kavita has told, that the nurses have to be trained well. Okay, उनको education देनी चाहिए. So I would like to, now education comes from the basic, and education has to be, oncology nursing in clinical setting starts from the basic in the education system. Now, with the vast experience in administration of running the regional cancer center, may I, sorry, may I ask Ms. Sri Lekha that what changes can be brought about in the nursing education system to better our nursing practice and clinical service?
Thank you, ma'am. Nursing education in India is governed through Indian Nursing Council at the national level and also through the state nursing councils at the state level. This INC advises government on nursing matters, prescribes nursing education syllabus, specifies minimum quality criteria for education institutions. And also this state nursing council inspect and accredit training institution, conduct examinations, monitor rules of professional conduct, and maintain an active register of nurses. So I feel that there is a gap in nursing sector between service and academia is wide. As per the industry experts, just 30% of BSc nursing graduate today are employable and possess the requisite skills to get privileged to work independently. And usually the hospitals spend 3 to 6 months and incur high training costs to make undergraduate trained nurses job ready, often suffer loss in terms of return on investment due to high attrition rates among nurses, especially within the first few years of training. As a CNO of the cancer center, I often felt that most of the undergraduate trained nurses joining the services are not immediately employable. Induction training, as all of you know, is mandatory. Apart from this, these hospitals are trained in conducting training for several months to enhance the skill of this newly hired nurse before they are deemed to be adequately qualified to deploy to patient care. They can be given privileges accordingly only. So we often suffer loss in terms of investment due to high attrition rate and training cost. As a clinical nurse, I would suggest a few changes that may incorporate into the existing system to overcome this hurdle. First of all, integration of nursing education and service in India will help in enhancing student learning and facilitate meaningful links between theory and practice. Though this knowledge exchange occurs between educational institute and the service area where the students are placed. The dual role notification from Indian Nursing Council in the year 2019 is issued with this aim. That has been made into practice. The concept paper attached as part of this notification is extracted from different success models in practice from some of the institutions of the country. The nurse educators to spend time in clinical practice, updating their clinical skills and re-experience the realities of practice. That may be one of the way. We may start from the level of educators, mandate clinical experience of working in hospital for becoming a nurse teacher. Exposure and experience in working in hospitals coupled with comprehensive teachers training will better equip this faculty to teach the student nurses. For existing nurse teachers in academics without clinical exposure, certification programs can be introduced. And also another thing, I would suggest that faculty exchange programs. This can be done through bi-directional exchange agreements, visiting faculties at national and international level and conducting of classes online in agreements with foreign universities. Indian nurses are prepared to serve at the international level. These trans-cultural exchanges definitely will add to their competencies and vision. For example, MOU of Indian Nursing Council with University of Houston College of Nursing with regard to nurse practitioner in critical care is an example for this. There are such many faculty exchange programs are done in many state councils that has to be extended to whole of India. Another thing is high fidelity simulations. Simulations are getting wider acceptance in nursing education system where concept of patient safety and consumer protection are asset. The concept of sisters becoming teachers have to be modified. Anyone and everyone cannot be a teacher. In order to provide exemplary education, students have to be taught by qualified and specialized nurse educators. Provision of simulation training, especially in specified skilled areas, need to be implemented at undergraduate level. Simulations need to be given in opportunities for students to reflect themselves through adequate debriefing after the simulation exercises. The nurse educators need to develop and standardize appropriate evaluation tools for these simulation programs. And the thing in oncology nursing is nurse practitioners in oncology can be prepared to function in tertiary care settings. Rigorous educational preparation will enable the nurses to diagnose and treat patients with cancer as well as preventive and promotive care relevant to cancer. They can contribute in patient selection and admission to ICU and discharge, problem identification through appropriate assessments, selection and administration of medication or devices or therapies, patient education for the use of therapeutics, evaluation of knowledge of interaction of therapeutics, recognition and management of complications. So introduction of such a program in oncology can improve our practice. Another thing is interprofessional education and training in healthcare. I would suggest that for early sensitization and familiarization of students from various professional courses like BSc Nursing, MBBS, and other allied health courses in India, a module should be included in the first year of curriculum of undergraduate health professional courses to educate students on roles, responsibilities, sensitivities, boundaries of each and every healthcare professionals. Doctors and nurses should be sensitized to respect each other as partners to help remove disparity and antipathy towards each other in the healthcare profession. Introduce interprofessional cases in the final year of undergraduate professional courses where students from various disciplines can come together and work in hands and on in a clinical setup. This exposure will help nurses effectively to function as a member in the multidisciplinary team. In case of oncology nursing, they can be a part of multidisciplinary tumor board also. This experience will enhance their contributions to such field. And the thing is high tech and low touch, high touch approach. With this present day nursing education is preparing students to maintain human element of nursing care with the help of sophisticated technology. That is introduction of patient care and evidence-based practices, quality improvement, then use of information technology in nursing practice, especially with regard to hospital information system, electronic health record. Now robotics is there in curriculum to accustom student to such a system early when they are a student itself. For enhanced this adoption of technology in nursing education and practice, it is critical to train the faculty also so that they can leverage technology to teach and train. Then another thing is e-learning courses. So during this COVID pandemic situation, there won't be regular classroom education. So e-learning opportunities can be given. There are certain e-learning courses which are offered by Infusion Nursing Society, Indian Nursing Council, World Council of Enterothermal Therapists. All these will give major input to student nurses so that they can extend their knowledge background. And also over the past few years, there are dramatic increase in the newer nursing roles within oncology. There are certain specialties which a nurse can manage with essential training in oncology, like nurse-led clinic, which is a major initiative, which can give rehabilitative, supportive, and symptom management to cancer patients. Lymphedema care, stoma care, brachytherapy nursing, head and neck postoperative rehabilitation, insertion of central venous catheters are all can be developed as a subspecialty. In our center, it has been made as a subspecialty. And short-term training in all these courses, if given to nurses, they will improve their academic background as well as their skill in providing care to the patient. And the thing is post-registration. I feel that most of the BSc and MSc graduates are reported to move predominantly to educational position in the public and private sectors. Why? Because many countries where clinical nursing carries a low status as they think. Academic qualification are valued as a potential route of clinical practice into higher status and better paid jobs in education. So remuneration and job position are to be designed in such a way that nurses with higher qualification are placed in better position in clinical settings. Such highly qualified nurses in clinical setting definitely will improve the scope of practice in nursing. And also, apart from the basic education, we need to strengthen our in-service education program. And majority of the accredited hospital has a mandatory training program, but others have to come up with this. Our nursing council has to give mandatory CN credit hours to such training program, which will definitely empower our nurses. So I feel that there is a need to broaden the scope of nursing curriculum by adding more concepts like competency-based model. I would suggest that competency-based model and critical thinking among nurses, which is surely empower nurses to act as a backbone in the hospital, surely to oncology nursing services also.
Thank you very much, Srilekha. That was a very in-depth understanding and what we have got of your concept for us to amalgamate the education system to the clinical services. May I put forth the next question to Madam Madhumita? The scenario of treatment to oncology setting is changing. So along with that changes the adaptation of nursing services too. So now how we have understood that the amalgamation is important. For example, Madam Kavita has told that log bhag jate hai, they are not keen to working because they're afraid of certain things. So Madam Madhumita, with a background and of army as well as the head of regional cancer center, can you please tell me what are the different roles of oncology nursing do we envisage for nurses in the Indian scenario so that we can attract them when the attrition rate can be reduced?
Yeah, thank you, Sindhu. Like you see, like for the over the last few decades, we have seen that the cancer care has come a long way from the general nursing care for the patients with cancer using primary care at the bedside and comfort measures to the development of the oncology nursing as a specialist, as a specialty, you know, and this has been as a specialty, and this with a defined knowledge. The nurses are now, oncology nurses have specific knowledge about oncology, and they are supported by research and expert practice. Now, oncology nurses, they are professionals, you know, with a vast experience, and they have a very diversified role. They work with a multidisciplinary team, and they work in a wide variety of sectors. Like if you take in community or in OPD, they take care of patients. They they focus on cancer screening. They focus on detection of cancer and in prevention. Whereas in hospital scenario, they take care of the patients who are suffering from cancer. They become a communicator and an educator as a counselor to the families of the patients, you know, who are suffering from cancer. Then they care patients who are cancer survivors, and also they provide care at the end of life. Not only this, they also are, you know, working in hospice care. They are working in radiation therapy facilities. They are working in standalone facilities. They are working in private oncology clinics. They also work as home care, healthcare along with home healthcare agencies. They are also working at and giving care at home level also. So, you know, the nurses, they really have a diverse role. You just cannot say that oncology nursing role is limited to one. No, their role starts from prevention till, you know, till the treatment and end of life care. So as we see that the healthcare system is changing, you know, and new scientific discoveries are integrated into the cancer care. So the role of oncology nurse is continuously evolving. You know, new roles are coming up and new dimensions are coming up for the oncology nurse. So if you want to tell me that, yes, if I want to see how the Indian scenario should focus on for the oncology nurses, then as Srilekha also said, that yes, we should emphasize on various certificate courses which should be made available to the nurses so that they become a certified pediatric oncology nurse, or they may become a pediatric hemato-oncology nurse, or they can become a blood and marrow transplant certified nurse. They can become certified breast care nurse, or they can even become advanced oncology certified nurse. And also along with this, you know, we should encourage and we should allow the nurses like to become, we should emphasize on oncology research nurse. Like oncology research nurse, you know, they coordinate with the clinicians for a clinical research purpose. They guide the patients, they coordinate with the patients, follow the follow-up care, they coordinate with them, they educate the patients with the, the new medicines, the study medicines, what are happening, they go with the clinical trials. Even we should emphasize on oncology nurse practitioner. Then we should have oncology nurse navigator. See, oncology nurse navigator is very important. This practice is there abroad. So, but we should, in India, we should also try to inculcate this. Why? Because oncology nurse navigator, she's a link between the nurse, between the patient, and between the multidisciplinary team members. She helps the patient in when the moment the patient is diagnosed, she helps the patient to link with the different consultants so that the patient's treatment is smoothly taken care of. Then she helps in the follow-up care and so forth. Then the nurses should be encouraged as radiation oncology nurse. And a new thing which has come up, which is there in Australia, is breast care nurse. This breast care nurse, they are registered nurses who have specialized and have vast experience and knowledge in breast cancer and breast care nursing. And they play a significant role in taking care of patients who have suffered from breast cancer. And obviously, clinical nurse specialists. So this is what I think we should look into if we want our nurses really to grow in a super specialty area. Thank you.
True, very true, ma'am. Very true. Thank you very much for the roles, what you have mentioned to us. I'm sure the people who are listening to us will be spellbound with the extended and the expanded roles, what you have mentioned, so that many more nurses will be interested in taking up oncology, and that is going to be the future ahead. Now, taking over from here, and with the amalgamated issues and the mentions, what you all have told, that is what Madam Kavita, Madam Madhumita, and what Srilekha has told us. What I have understood is that training and capacity building is the most important foundation of any institute. To train and induct novice nurses requires a systematic effort. And also what requires is to continue the training of the nurses who are working with us. So may I ask Ms. Surya to provide us an insight on better or innovative training techniques for novice nurses and also for the nursing staff working in hospital for improving the patient outcome related to oncology. Over to Surya.
Thank you, ma'am. Thank you for the question. So as the previous panelists were discussed, oncology nursing is a specialized area of nursing in which the nurse may require specialized practice as well as skill and knowledge to care the patient or to provide best care to the oncology patients throughout their cancer journey. As we have already discussed, the cancer journey starts with the time the patient goes with the diagnosis. Even the nurse has role in preventive as well as screening aspect of cancer as well. So till the end of life care, the nurse is responsible to provide appropriate care to the patient. But when we have a novice nurse into oncology, which is an alarming situation to the oncology nurse, without providing proper education, proper skills, we might not expecting them to handle a patient independently because they are having zero experience in nursing. They might not be having knowledge regarding oncology as well, because oncology may be a new entity for them. So there may be many gray areas for them into oncology. So whenever we will be looking into these new budding nurses, the novice nurses, I must say, which is one of my favorite category also, because teaching them, providing skills for them and expecting the same to practice at bedside for a novice nurse is very, very easy, because she doesn't have a previous burden of experience, what I say. So we have to pay special attention when we plan any training program for the new novice nurse, because as we already said, they are having zero experience, zero exposure in patient care. So when any nurse coming to any hospital, we will be focusing upon an onboarding induction program. So induction program must involve basic cancer care curriculum for the novice nurse, so that she will be sensitized. What is the role expected out of her when she will be at patient bedside? How can she able to identify the needs of the patient? How can she satisfy the needs, or how can she meet the need of her patients when she will be assigned with patients? So this sensitization should happen at the induction phase itself. It also has to focus on the enhancement of the skill and knowledge as well, especially in terms of handling of chemotherapy, administration of the chemotherapy, knowledge into the chemotherapy to drugs, and spill management. These are the practical entities we need to look into when we'll be conducting an induction program for any novice nurse also. And other next focus has to be on the practical aspect of procedures. The other case what we need to provide to a patient, that has to be ensured in the induction phase itself. As Srilekha ma'am already said, simulation is the best way of conducting the practical trainings before we send them to the patient bedside, so that they will be able to understand their own competency levels, and they might be having a knowledge how they will be performing the same at patient bedside. So they will also know to improve their knowledge as well as the skill. So mentorship or preceptorship program is the next thing that will be helping a novice new nurse to cope up with the oncology nursing care, because when she will be at patient bedside expecting to provide patient care to the cancer patients, so she is not having experience, just because of which she might not be able to fulfill the complete needs of a patient. So mentorship program, we will be assigning a senior nurse with the new nurse, so that the senior nurse will be always there to help the new nurse in the different care continuum of a patient, and the new nurse can also learn from the senior, and she can also pursue the skills from the senior nurse. So this will also help a new novice nurse to cope up with the cancer care of a patient. Next is competency-based continuing education, which is an important key to improve the skill and knowledge of an oncology nurse, which also focus on enhancing the practical as well as the skill of a nurse also. So when we'll be doing this competency assessment, we can able to understand the gap in actual nursing practice, what is expected out. So this way we can identify the training needs, and we can fulfill that training needs, by which the new nurse will be having new nurse will be enhancing her knowledge as well as the skills what she requires to fulfill the need of a patient throughout their cancer care, which is also an important thing to follow when we will be sending a new nurse to bedside. And continuing nursing education is also having a great effect on enhancing the new skills which has been upgrading in terms of drug, in terms of skill, in terms of other practical aspects of patient care, which can be by on-job training, which can be by some conferences, which can be by some other training programs. Nursing tumor board is also having a great value in improving the nursing skill as well as knowledge, because the difficult cases what we can discuss in nursing tumor board, and the new nurses, the onboard nurses also will get knowledge on the same, and this will also help both the nurses, like new as well as the old nurses, to enhance their practice. So this is all from my side regarding the question. Thank you.
Thank you very much, Surya. Thank you very much. As Surya has mentioned, getting trained is very important. And one of the things which COVID-19 pandemic has taught us, or has given us, we have got re-engaged in adult training. For example, what has happened today is a beautiful outcome of COVID-19 pandemic. We all have got connected from throughout India and across globally. If it was not COVID-19 pandemic, we would have to meet people personally. We would have to wait for a conference to come up. Over here, the pandemic had to hit us just to inform us that we can have webinars every month. We can have Zoom meetings every month. We can have online certificate course, which is much more feasible without meeting and flying across interstate to meet people. So this is a beautiful outcome and a positive outcome of the COVID-19 pandemic. Now, just to summarize what we all, the panelists, the esteemed panel members have spoken, let me just go through point by point. We need to find out ways to reach each and every nurse across the country. And this is what Madam Kavita has mentioned. And as Madam Srilaka mentioned, to amalgamate nursing education to service, to have better nursing educators to teach them better. And one of the beautiful sentences which I heard from Madam Madhumita was oncology nurse navigator or sutradar. That is what I understood. That is to link the patient to for a better patient outcome, for a better follow-up. I'm sure that will have a better positive outcome. To conduct online or certificate courses so that we can reach out to more and more nurses across the country so that we can improve the nursing services across. And to introduce, we may have to introduce, there is no other way out. With the last 2020 gone and 2021 also going, I think clinical services of the nursing education is going to be badly hit. The clinical services may have to introduce high fidelity simulators to improve the training services across our institutions. Thereby, I thank each and every panel member and also the organizers, especially Dr. Lalit Sharma, who got connected with us. Thank you very much. Thank you, Madam Madhumita, Surya, Kavita Sharma, Renu, and Madam Srileka for the inputs which you have given to the panel. Thank you very much.
Thank you.
Thank you, Sindhu. Thank you, Dr. Lalit.
Thank you. Thank you so much. Thank you, Madhumita ji. Thank you, Sindhu ji, Srilekha ji, Surya ji, Kavita ji. Thank you. Thank you so much. Thanks to you all. And I think it's a beginning. And as Sindhu has rightly mentioned, that COVID has taught us a lot of things. So I think we can have more and more of such virtual meetings and we learn from each other. At least for me, it was a great learning experience. And I have conducted first webinar purely managed by the nurses, in fact, this time. So I'm so much thankful and grateful to you all for your excellent inputs, and we hope that in future we will have more and more meetings. With this, we end up this meeting, and I thank Pankti and Roshni and Rajesh Sharma and the Mice Idea teams for helping us. I thank my co-directors, Dr. Hemant Malhotra and Professor Gopala Kawali for helping us. I thank all my foreign faculty for sparing their time in the early morning hours. And with this, we end up this meeting. And thank you so much all and have a safe stay ahead. Thank you.
Thank you. Thank you, sir. Thank you.
Bye-bye. Tata.
Bye, sir.